Um, is my slide visible, sir? 3D anatomy?
Yes, it's visible.
Okay. Okay. Good evening, class. So today is another exciting day for basic. So today we'll be learning basics regarding elbow and wrist, as well as basics regarding the common pathology. So it is a very big topic. So today we'll be we'll be touching the topic which are common in pain clinics. So, and gradually after this, I think we'll go to the advanced classes. Okay. So today let's to diagnose the disease or to elicit history, we need to understand the anatomy as well as sono-anatomy of the patient for you to be able to diagnose as well as for the treatment purpose also. Okay, so in the wrist, in the elbow, basically we all know elbow joint is formed by the distal end of the humerus and the proximal part of the radius and the ulna. So ulna is in the medial aspect and the radius is in the lateral aspect. Let's start with this big bone. Okay, so this is the distal end of the humerus and it articulates with the proximal part of the radius as well as proximal part of the ulna to form the wrist joint. Okay, and elbow joint, sorry for that. So, and this elbow joint is basically reinforced by various capsule as well as ligament in the medial aspect as well as lateral aspect. So let us, this one is the articular capsule of the elbow joint. If we remove this, let us remove this, then we can appreciate there is a articular surface of the or articular end of the humerus. And if we read so these are the lateral aspect are the part of the lateral ligamental complex. So this is the annular ligament, as we all know. It wraps the head of the radius. Okay, it wraps the head of the radius around, and this is one of the part of the lateral ligamental complex. So let us remove that. So this ligament is basically the radial collateral ligament. These ligament reinforces the elbow joint. So let's remove that also. So coming to the medial aspect, so I'm basically removing all the ligaments one by one. So this is also a part of the medial ligamental complex and also known as the ulnar collateral ligament. Okay, let's hide this. So once we remove all the ligaments and the capsule, then the elbow joint is exposed. Okay, so as you can see, this the lower part of the distal end of the humerus is the articular surface, and in the lateral aspect you can see a capitulum which is more rounded in structure, and in the medial aspect there is an inverted V or V-like structure. So this is a trochlea part of the distal end of the humerus. Okay, so if you can see here, this is the rounded structure. Lateral aspect articulates with the proximal part of the radius, and the medial aspect, okay, the trochlea, V-shaped trochlea. We can very nicely appreciate this in the ultrasound. It articulates with the trochlear fossa of the olecranon process. So this is the ulna bone. This is the ulna. Okay. So as you can see, it has two processes. Anterior, it is a coronoid process, and posterior, it is a olecranon process. So this olecranon process, as well as the this coronoid process, so it forms a groove and it articulates with the distal part of the humerus. And in doing so, it forms the hinge type of synovial joint. So this trochlear surface basically forms the hinge type of synovial joint with the distal end of the humerus. But it is not so with the radius. This radius articulates with the distal end of the rounded capitulum part of the humerus and forms the pivot type of synovial joint. So it has a pivotal type of synovial joint in the lateral aspect, but hinge type of synovial joint in the medial aspect. Okay, let's concentrate to this humerus. Okay, so if you see the distal end of the humerus, you can see there is a two bumps. Okay, in the medial aspect there is one bump which is known as medial epicondyle, and in the lateral aspect also you can appreciate a bump here in the lateral end of the humerus. So that is called lateral epicondyle. So it has a great clinical significance because many patients will come with a medial elbow pain where the common diagnosis would be like Walker's elbow, where there is a problem with the flexor tendon getting attached with this tubercle or this bony projection. And in the lateral aspect, we all know lateral elbow pain. There are a condition known as tennis elbow. Okay? So it is basically the ligaments which are attached to the tendon which is attached to the lateral epicondyle. There can be pathology in that. Okay, so these are the of very much clinical importance, and it can be very nicely palpated. You can just palpate the bony projection in the at the distal end of the humerus at both sides. Medial side it is medial epicondyle, lateral side it is lateral epicondyle, and in the anterior aspect there is two fossa in the distal end of the humerus. Okay, so this fossa is basically a coronoid fossa, because in this coronoid fossa, this coronoid process of the ulna will come into this fossa when the elbow is fully flexed. Okay, so when the elbow is fully flexed like this, what I'm doing here in this position, the projection, this coronoid projection will come into this fossa known as coronoid fossa, and the lateral aspect also there is one small fossa is here. This fossa is known as radial fossa. So in this radial fossa, the radial will come this radial fossa when the elbow is completely flexed. Okay. Now let's see the posterior part of the distal end of the humerus. Okay. This posterior part of the distal end of the humerus, there is also a big fossa is here. This is known as olecranon fossa, where the olecranon process, this is the olecranon process. As you can see, this olecranon process will go into this fossa when the elbow is completely extended. Okay, when the elbow is completely extended like this, how am I doing? So in this, bony projection will go inside here. Okay, so here you can see the radius articulating with the humerus from the radiocapitellar joint. So this is the radiocapitellar joint, and this is a humero-ulnar joint or ulno-humeral joint. So there is another small joint is around here, which is basically between the radius and ulna. So there is a radial groove is here in the lateral aspect of the ulna. So here, the head of the radius also articulates with this. So it forms the superior radioulnar joint. So actually, it has three small joints. Okay, and in the posterior aspect, let us put the muscles around here. Okay, so if you see the elbow. So here, this 3D anatomy is with the muscular structures around the elbow. So in the muscular structure around the elbow, in the anterior aspect of the elbow joint, you can see two big muscle. One is this biceps muscle is there. The name is biceps because it has two head. This is the short head, and this one is the long head. So both long head and short head merges with each other and forms the common bicep tendon, and it gets attached to the radial tubercle with the radius. Okay, so this is one muscle, most superficial muscle in the anterior aspect of the elbow. When I'll be doing a sono-anatomy, I'll be showing you the this cut section view of this biceps tendon. So if we remove this biceps, if you hide this biceps, the next muscle layer, deeper muscle, is a big muscle, chunk of muscle known as brachialis. Okay, this is one of the home page. When we are doing the scan of this elbow joint, we will be locating this brachialis muscle. Okay, so as you can see, there is a big chunk of muscle just in the anterior aspect of the elbow, that is brachialis, and in the lateral aspect there is this muscle is basically a brachioradialis muscle. It comes from the humerus and it goes to articulate. It goes to the distal end of the radius. So this one is brachioradialis, and in the medial side there are a group of flexor muscle known now starting with this pronator teres, and these are all common flexor tendon which is getting attached with the medial epicondyle of the humerus. And if you see the lateral aspect of the elbow joint, you can nicely see this is the brachioradialis is the muscle, most lateral aspect. Then comes this extensor carpi radialis longus muscle. So this, if you see this extensor carpi radialis muscle, it doesn't insert in the lateral epicondyle. Okay, it basically is joining with the ridge in the lower part of the humerus, and these four muscle are basically a common extensor tendon. So you will be appreciating these four muscle. It forms the common tendon and gets attached to the lateral epicondyle. So if there is any tear, or if or there can be tendinosis in this aspect, So common clinical pathology in the lateral aspect is basically a tennis elbow, where the common extensor tendon, which is getting attached to the lateral epicondyle, there will be a pathology or tear or tendinosis in that. So if you see the posterior part of the elbow joint, let me. So if you see the posterior part of the elbow joint, there is one big muscle that we'll be seeing. This one is triceps muscle. Okay, this as the name suggests, it has three heads. Okay, that's why it is called triceps. So the marked area is basically a central tendon of the triceps muscle, and in the medial side there is a long head of the triceps muscle, which basically merges with the central tendon, and with common tendon it articulates with the superior aspect of the. This one is the olecranon process of the ulna. So it articulates with the superior surface of the olecranon process of the ulna. And in the lateral aspect, there is a lateral head. So small lateral head is there. And in the most deeper part of this posterior aspect of the elbow, this one is the medial head of the triceps muscle. So most inner one or deeper one is the medial head of the triceps. And in the superficial, there are three structures basically. In the medial side, there is a long head. In the lateral side, at the lateral side, there is a lateral head. Both of these merges with this central tendon. And finally, this medial head will also merge with the central tendon and gets attached with the superior surface of the olecranon process. Okay, so this is basically a various musculature around the elbow joint. So in the sono-anatomy, I'll be showing the medial side, lateral side, our home page, and as well as we'll be saying the common area where olecranon bursitis will be. So this the more superficial to the triceps tendon, and at the site of attachment will be the olecranon bursitis, and we'll be also seeing the elbow joint from behind as well as in front. So these are the structures that we'll be seeing. Apart from this, we'll be also seeing in brief regarding various nerves around the elbow joint. Okay, so there are three main nerves around the elbow joint. In the medial aspect, this one is the median nerve. Okay, this median nerve is in the medial aspect of the elbow joint. In the lateral aspect of the elbow joint is the radial nerve. So this radial nerve is basically between the radial nerve is, as you can see, it is basically between brachialis muscle and brachioradialis muscle. We will not be tracing the entire course of the radial nerve, but we'll be just seeing where it is located. And as you can see in this picture, between the brachialis and brachioradialis will be this radial nerve, which will be in the lateral aspect of the elbow. And in the posterior aspect of the elbow, there is one nerve which is known as the ulnar nerve. So this is the ulnar nerve, which is in the posterior aspect of the elbow, which goes behind the medial epicondyle, and then it goes to the forearm. So these are the structure that we will be seeing in the sono-anatomy. Okay. So if you want to see this structure revised, I can repeat any structure in the elbow joint. Any structure you want to repeat in this elbow joint? Okay. Okay, so now coming to the wrist joint. Okay, so wrist joint.
So can you once again explain the ligaments?
Ligaments of around the elbow joint.
Yes, sir.
Okay, so basically the ligaments around the elbow joint is in the advanced class, but I'll be showing in this 3D anatomy. I'll be showing. Okay, so this is basically the elbow joint. Actually, this is the free version, so the ligaments are not nicely seen, but I'll try to explain. Okay, so this is the distal end of the humerus, and these are the proximal part of the radius and ulna. Okay, so this one is the capsule. I'll be removing this capsule. So once I hide, then there are three ligaments. So basically, there is a medial ligamental complex at the medial side, and in the lateral side, there is a lateral ligamental complex. Okay, so the medial ligamental complex consists of three parts. Okay, anterior band. It has an anterior band. It has a posterior band, and it has a horizontal band. So these are the three part of the medial ligamental complex. So this one is the anterior band. And okay, just behind the anterior band, this one is the posterior band. Okay, and this one, not this one. and this one is the horizontal band. Okay, so altogether it is known as the medial ligamental complex, and it is also known as medial the ulnar collateral ligament. Okay, so this as a whole is also known as ulnar collateral ligament, or basically it has three parts: anterior band, posterior band. Okay, posterior band is behind, and this one is the horizontal band. So these are the three ligament forming the medial ligamental complex. And in the lateral side also, this joint is reinforced with one lateral ligamental complex. And this in the lateral ligamental complex, there are three structures. One is this annular ligament. We all know annular ligament, which will be wrapping around the head of the radius. And another is this one is the radial collateral ligament. Okay, so it extends from the distal end of the humerus, and it comes and articulates, it merges with the annular ligament. And in the posterior side, it is not shown in this picture, but in posterior side, this one, it is basically, these are the two ligaments. This lateral aspect of the ligament is known as lateral ulnar collateral ligament. So you can see it is going and it is getting attached with the ulnar. So this is the lateral ulnar collateral ligament. So this one was medial ulnar collateral ligament. Okay, so this one was medial ulnar collateral ligament, but this one is the lateral ulnar collateral ligament, which is a part of lateral ligamental complex. Okay, so three ligaments in the lateral side and three ligaments in the medial side. Actually, it is this is in the advanced course, but still, so these are the ligaments which are reinforcing the elbow joint. Okay, are you clear?
Yes, sir. Thank you, sir.
Very, very good. Okay. So any other structure that I would that you want me to repeat? Okay. So let's see the wrist joint. Okay. So wrist joint is also it is formed by the articulation. This one is the 3D structure of the wrist joint, the skeletal structure. This one is the extensor retinaculum, which will be basically covering the entire circumference of the distal end of the wrist joint. Okay, so and it forms basically a extensor retinaculum here, and underneath the extensor retinaculum, all the extensor tendon will come, and it goes under this extensor retinaculum, and it goes to the various digits. Okay, I'll be showing you in the muscular. I'll be putting it in the muscular structure, and you'll be clear in this. Okay, and and this one is the palmar surface of the wrist joint. Let us hide this. So if we let us hide this. Okay, so these ligamental structure I'm excluding because these ligamental structures are in the advanced class. Okay, so I'm basically hiding these ligamental structures. Okay. 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 So basically, if you see this, this is the distal distal end of the radius and ulna, and proximal part of the carpal end of the bone. And this wrist joint is actually formed by the distal end of the radius articulating with the proximal row of the carpal bone, not entire proximal row of the carpal bone, but it articulates with the scaphoid. So there is one mnemonic, she looks too pretty, try to catch her. So this is the mnemonic for the carpal bone, starting from the radial side. This one is the scaphoid bone, and this one is the lunate bone, and lateral to this, medial to this is a triquital, and above the triquital is this rounded bone is a pisiform bone. So this is four bones basically form the proximal row of the carpal bone. This proximal row, out of this proximal row, scaphoid, lunate, and part of triquital basically articulates with the distal end of the radius to form the wrist joint. Okay, the distal end of the ulna doesn't take part in formation of the wrist joint. Wrist joint is only formed by the distal end of the radius with the three lateral carpal bone of the proximal row. So this is the bony structure of the wrist joint. And if I remove this, so let us hide this. So as you can see, in the wrist, there is a distal end of the radius which articulates with the proximal row of the carpal bone. So this is U-shaped and this one is T-shaped. This is basically a cup, inverted cup or U-shaped. And this U-shaped row of the carpal bone consists of most lateral is the scaphoid, towards the radius is scaphoid. It is a boat-shaped structure, which also forms the majority of the wrist joint. And the second bone is a lunate bone. Okay, it forms the radiolunate joint, and the medial to the lunate is the triquital, and above the triquital is the pisiform. So these are the four bones which forms the proximal row of the carpal bone, and the distal row of the carpal bone is formed by so these are the trapezium from lateral to medial, trapezium, trapezoid. Okay, so this one is trapezoid, and this is capitate, and finally hamate. So this is the hamate with a hook of hamate. Okay, so hamate, capitate, trapezoid, and trapezium. So these are the various carpal bone, and these carpal bone basically articulates with the metacarpals, 5 metacarpals, and then finally it articulates with the various phalanges. So if you see the anatomy, so basically I'm basically hiding the. So it is basically the distal end of the radius and ulna, and the various the carpal bone. So we'll be appreciating these proximal row of the carpal bone as well as the distal end of the radius and ulna in ultrasound examination. Okay, so if I put various muscles or the ligaments around the hand, uh, around the wrist joint. So suppose this is the wrist joint, as you can see. Um, So if you see this, these are the various flexor tendons going into the from forearm to hand. And if in the posterior side or in the dorsal aspect, you can see all the extensor tendon going to the hand below the. This is the extensor retinaculum. So one of the peculiar thing about this is, so if you see in the wrist joint, all the extensor muscle or tendon will all the extensor muscle will eventually form the tendon, and these tendon goes below the extensor retinaculum, and it goes to the various digits. Okay, and while doing so, this is the extensor retinaculum. From the extensor retinaculum, there are various septas coming and getting attached more deep to the radius and ulna, and it forms compartments, and it forms various compartments, mainly 6 compartments it forms, and through these 6 compartments, all the extensor tendon will go from the forearm to hand. So if you see the individual compartment, uh, um, so if you see the individual compartment, if you see these are the flexor, these are the extensor tendon. Okay, the first compartment is formed by the these 2 tendons. So first one is abductor pollicis longus, and second one, this tendon is the extensor pollicis brevis. So the mnemonic is longus brevis, longus brevis, longus. Okay. So if you want to remember the mnemonic of this, starting from we always start alphabet with A. Okay. First one is A, abductor pollicis longus. So first one is longus followed by brevis. So first one is A, abductor. This one is going to the thumb, so it is pollicis. And first one is longus. So abductor pollicis longus is the first tendon. Then comes the tendon. This one is extensor pollicis brevis. Remember, longus followed by brevis. And these 2 tendons forms the first dorsal compartment. And second compartment is formed by the extensor carpi radialis longus. So always first is longus. Then comes extensor carpi radialis brevis. So these 2 tendons forms the second compartment, and third compartment is formed by this long tendon. Okay, this is extensor pollicis longus. Okay, look, it is coming and it is crossing over the compartment number 2, and it is going towards the thumb. So as the formula is, first one is longus, abductor pollicis longus, followed by brevis. This is extensor pollicis brevis. And in second compartment, first one is longus, that is extensor carpi radialis longus. Second one is 2 tendon. Okay, second one is extensor carpi radialis brevis. So this is second compartment. Third compartment, it should end with longus. So it is extensor pollicis longus. So this one is going from here. It basically there is one small tubercle here. So I'll remove this. Let's hide this. Okay, so here you can see. So there is one tubercle here, which is known as Lister's tubercle, which is very nicely seen in ultrasound. So there is one, this Lister tubercle, which is at the distal end, radial end of the radius. Okay, it basically separates the second compartment with the third compartment. So you will be nicely seeing there is a bony projection, like mountain-like bony projection is here, very nicely seen in ultrasound. This will divide, or this is one of the landmark by which we know that which one is the second compartment and which one is the third compartment. So Lister's tubercle, medial to the Lister tubercle is the third compartment, which is extensor pollicis longus, and comes the fourth compartment. So fourth compartment basically comprises of these tendon, that is extensor digitorum, all going to the digits, and one extensor indices. So there are 5 tendon in the fourth compartment. 4 tendon are extensor digitorum tendon, and another tendon is this one, this extensor indices. It goes to the this index finger. Okay, and fifth compartment is basically this one is extensor digiti minimi, as the name suggests. As you can see, this is going towards the little or pinky finger, and the finally sixth compartment is this extensor carpi ulnaris. Okay, so these from the retinaculum, the extensor from the extensor retinaculum, septa will come, and it gets basically divides this dorsal compartment into 6 different compartments. So you do have to remember the name of the all the tendons, and the most commonly of clinical significance is this first compartment, where there is pathology known as decumbens tenosynovitis. Okay, so this decumbens tenosynovitis can happen in the first compartment, which can be very nicely appreciated in ultrasound. So we'll be seeing in ultrasound also this one. So first compartment will again revise this 2 tendons. Okay, starting with A, abductor, and ending with longus. So abductor pollicis longus is the first tendon. Second tendon is extensor pollicis ending with brevis. Okay, longus brevis. So first compartment are these 2 tendons. Second compartment are basically this one, extensor carpi radialis longus, and another one is extensor carpi radialis brevis. Okay, longus first, then comes brevis. So these 2 tendons are of second compartment. So third compartment has only 1 tendon, that is extensor pollicis longus, and it is coming from here, and it is going away laterally, crossing over the second compartment, and it is going to the thumb, distal end of the proximal phalanx of the thumb, a distal phalanx of the thumb, and then comes the fourth compartment. Okay, fourth compartment, as we know, it has 5 tendons. This is extensor digitorum going to the second to fifth finger, and one more tendon is there. This one is extensor indices, which is going to the this index finger. And in the fifth compartment, normally this fifth compartment is usually located just above the radio-ulnar joint. Okay, in this 3D anatomy, it is not nicely shown, but in sono-anatomy, we can very clearly nicely see this fifth compartment is just over the this distal radio-ulnar joint, and finally the sixth compartment is the extensor carpi radialis, extensor carpi ulnaris. Okay, so we in ultrasound will be nicely seeing this dorsal compartment, and in proximal part, in the palmar aspect of the hand, we'll be also appreciating here. If you can see here in the palmar aspect, let us go to the nervous system. Okay, here it is very nicely, I think it is nicely seen in this one. So in the palmar aspect, okay, so this palmar aspect, you can see in the dorsal aspect, all the tendons were going below the extensor retinaculum. Then it was going to the hand. But in the palmar aspect, it is not so. As you can see, there are main 2 tendons doesn't go underneath this flexor retinaculum. So this is the extensor retinaculum. I'm hiding this. As you can see in the palmar aspect, so these are basically the flexor these are basically the flexor tendons. Okay, as you can see, some flexor tendon doesn't go into the. This one is the flexor retinaculum, and this flexor retinaculum basically forms the tunnel through which various tendons, not all tendons, but most of the tendons of the forearm goes into this through this tunnel and goes to the hand. And along with this tendon, there is one very important nerve which is known as median nerve. So as you can see, this is the median nerve. This median nerve also goes below this flexor retinaculum and it goes to the hand. So this is one of the most potential site of entrapment of median nerve, commonly known as carpal tunnel syndrome. And this carpal tunnel syndrome is a most common entrapment neuropathy, peripheral entrapment neuropathy. As you can see, this nerve, along with this nerve, 9 different tendon goes through this or below this, beneath this flexor retinaculum and comes to the hand. So this is also one of the important clinical, in the clinical perspective, this area is also very much important, as we do commonly get many patients with carpal tunnel syndrome, where we can measure the cross section area of this median nerve and diagnose it as a carpal tunnel syndrome, provided patient is symptomatic. And the peculiar thing in this area is there are two tendon or three tendon that is not going through this flexor retinaculum. One is in the medial side is the flexor carpi ulnaris. It doesn't go through the flexor retinaculum. Okay, another tendon is this one is palmaris longus. This palmaris longus also merges with the flexor retinaculum, but it doesn't go beneath the flexor retinaculum to hand. And finally, there is another tendon. This is the flexor carpi radialis. Okay, this flexor carpi radialis also doesn't go below this flexor retinaculum. Okay, now coming to flexor retinaculum, as you can see, this median nerve, along with median nerve, you can see 9 different tendon going below this flexor retinaculum and coming to the hand. So these are basically the flexor digitorum superficialis, 4 different tendon of flexor digitorum superficialis, 4 tendon of flexor digitorum profundus, and one more tendon is there. This is flexor pollicis longus. So these 9 tendon, one is flexor in the lateral aspect is flexor pollicis longus, and in the middle is basically the upper row basically consists of flexor digitorum superficialis, and the deeper row basically consists of flexor digitorum profundus. And along with that, the median nerve also goes into this carpal tunnel and goes to the hand. So you have to know how to scan this area and how to measure the this median nerve diameter for carpal tunnel syndrome. And another thing here in the medial aspect, there is another small tunnel or canal which is known as Guyon's canal, and this Guyon's canal basically consists of the this ulnar nerve. Okay, this ulnar nerve doesn't go below the flexor retinaculum, but it goes above the flexor retinaculum, and it forms the retinaculum forms another ligament which is known as transverse carpal ligament. So the transverse carpal ligament and the flexor retinaculum, it forms a small canal, and this is known as the Guyon's canal, and through the Guyon's canal goes the ulnar nerve, which can be nicely seen in ultrasound. So these structure will be appreciating in the wrist joint. So dorsal compartment along with decuberrin, median nerve will be appreciating Guyon's canal, and another one more structure we'll be seeing is in the hand is basically pulley. So unfortunately in this 3D anatomy, the pulleys are not shown here, but I think Smruti will be showing you in her PowerPoint various location of pulley. But I'll be demonstrating where the pulley will be. Okay, so these are the pulleys are basically a band-like structure which reinforces this flexor digitorum superficialis and flexor digitorum profundus tendon, and it basically stabilizes this flexor tendon, and it basically binds this tendon along with the phalanges. Okay, these are the phalanges. If there is any rupture of this pulley or damage of the pulley, there will be bowing of this flexor retinaculum. So there are 5 pulleys, basically A1 named as A1, A2, A3, A4, A5. So these are the annular pulleys, and there are also cruciform pulleys. Between the annular pulleys, there will be a small crisscross structure. Uh, Cruciform pulleys are there. Okay, so these pulleys are unfortunately not shown in this 3D anatomy. I'll be showing you in ultrasound the first pulley, and in the maybe Dr. Smoothie has a part the slides where the pulleys can be nicely seen. All the the annular pulley as well as cruciform pulleys can be seen. Okay, and another structure here. There will be another. So these are the main structure that will be seen in ultrasound. Okay, so if there is any structure thing that you want to me to see in this repeat in this 3D ultrasound of the wrist, please tell me before going to the sono-anatomy. So one muscle I forgot to tell you is this one. Okay, so this one is pronator quadratus muscle. So this is our home page. We'll be identifying this pronator quadratus muscle and then going down to identify the median nerve, to scan the median nerve or to scan the wrist joint. We usually start with see this pronator quadratus as a landmark for our home page. So we'll be nicely seeing this flat muscle extending from the radius to ulna, which helps to pronate the forearm. Okay, so these are the structure, and we may also see the superficial branch of the radial nerve in the wrist joint, and three nerves we'll be seeing in the wrist joint. One is ulnar nerve, and then the main is the median nerve, and if possible, the superficial branch of the radial nerve also we'll be trying to see in the sono-anatomy. So if you want to repeat, I'll be repeating the anatomy of the wrist joint. Hello. Okay. So no questions. So let us start the sono anatomy of the elbow and wrist. Okay. Give me 5 minutes time to prepare my to prepare the volunteer. Okay. Can you see the picture, ultrasound as well as the volunteer picture? Excuse
No,
me.
sir. No.
I can see, sir. It's not visible.
It's not visible.
No, sir.
Okay.
Not visible.
Okay. Give me 1 second. Is it visible now?
Yes, sir.
Yes, sir.
Yes.
Yes,
Okay.
now visible.
Okay, very good. Okay, so this is my patient, and I'm trying to examine the elbow joint. So normally patient can be sitting for examination of the elbow joint, and we'll be scanning the elbow joint from front, medial side, lateral side, and from the posterior side. Okay, and to scan the elbow, we are basically using the linear probe. Okay, linear probe, and uh, first, let's see the structure in the anterior aspect of the elbow joint. So the home page for the elbow joint is basically the left side of the screen is the lateral side, okay, and the right side of the screen is the medial side of the patient of the elbow joint. Okay, so if you can see very nicely, I have put my probe just over. There is a crease in the elbow joint. Okay, just put your probe over that crease over the elbow joint, and you can see a nice big like pyramid like muscle. You can see in the base there is a wavy base. Okay, so you can see there is a wavy, like a wave of the ocean. Okay, that is basically a distal end of the humerus, and in the distal end of the humerus, left side of your screen or the marker side is basically the lateral aspect, where you can see a rounded capitulum. Here you can see a, so this one is our home page. Okay, so if I so for the elbow joint, basically this is our home page. I will stop here and I'll be explaining you in. Okay, so okay, so this is the home page for the elbow joint. My probe is just over the crease of the elbow joint. Okay, so when we put our probe here, there are various things you can see. Suppose this is basically a distal end of the humerus. You can see this is the roundest structure is the capitulum, and this V-shaped structure is the trochlea of the distal end of the humerus. And you can see this hypoechoic layer above this wavy structure is basically an articular surface of the distal end of the humerus. Okay, so let us. Okay, so you can see this hyperechoic structure is the bony part, and this one is capitulum, and this is trochlea. Here the radius will come here and gets attached with the capitulum, and here ulna will come and gets attached with the trochlea of the distal end of the humerus. And this hypoechoic structure is basically a articular cartilage of the distal end of the humerus. Okay, and above this is, you can see a big mountain-like muscle. Okay, this muscle is brachialis. Brachialis muscle is this. Okay, and above the back of brachialis and the top of brachialis is basically, this is the biceps, tendon of the biceps. So this one is the tendon of the biceps on the top of the heel, and this whole entire heel is formed by the brachialis. Okay, and in the lateral aspect of the brachialis is brachioradialis. This is brachioradialis, and in the medial side, this one is pronator teres. Okay, so if you see this one, this muscle is pronator teres. So this is the home page. Whenever we are evaluating elbow, first thing structure that you want to get is this home page. Okay, so once again, this home page can be very easily accessed when we just put our probe in the crease of the elbow joint. So you can very nicely see the capitulum. Okay, this one is capitulum, very nicely seen. Another is this one is the articular end of the humerus, and you can see V-shaped. This one is trochlea, where radius is getting attached. Okay, and you can see very nicely the brachialis muscle. Okay, very nicely seen brachialis muscle. And above brachialis, you can see a short axis view of the biceps tendon. And medial to you can see brachial artery, but very nicely bounding very nicely. and more medial to this is the ulnar nerve. Okay, you can put a color Doppler here. You can see, you can put a color Doppler here, and let's increase the gain. Okay, okay, very nicely seen. There are very important structure, very nicely seen here. Okay, so this one is again home page. Okay, so home page, not nicely seen. Okay, so home page again, this one is basically lateral side. So this one is the lateral side. This one is the lateral side. This one is the medial side of the elbow joint. And in the medial side, there is on the trochlea. Okay, this one is capitulum. And this muscle, big muscle, is basically brachialis muscle. Brachialis muscle. Above the brachialis muscle is the biceps tendon. And medial to this bicep tendon, this one is the artery. This one is brachial artery. And medial to brachial artery is basically, this one is the median nerve. This is one is the median nerve. And medial to the median nerve is this one is pronator teres muscle. Okay. And in the lateral aspect, there is this muscle is known as brachioradialis. So this is the structure home page that you have to identify. And between the brachialis, brachioradialis and brachialis, there is one nerve which is known as radial nerve. And between the brachialis and pronator teres, there is this one is the median nerve. So basically, in between the brachialis and brachioradialis, you will be identifying the radial nerve, and basically between the pronator teres and brachialis, you will be identifying this one is the median nerve. Okay, and this small nerve is hypoechoic nerve is the radial nerve. So this is the home page if you are scanning the elbow joint. So now here I told you, if I go medial to this, you can see very nicely where between the brachialis and pronator teres, you can see this one is the median nerve, and it goes, median nerve travels in between these two muscles. You can, in the center of the skin, you can see median nerve going between the brachialis and pronator teres. And in the lateral aspect, you can see very nicely see the radial nerve. Okay, radial nerve is between the brachialis and brachioradialis, and this one is the radial nerve. So these nerves are basically between the two muscle plane, and this one is the short axis view of the dot, red dot where I marked is the short axis view of the biceps tendon. So we can see this bicep tendon in the long axis also. So if you can see, I'm showing the long axis view of the biceps tendon. So as you can see, I have positioned my probe along the long axis of the, so you can see very nicely fibers of the biceps tendon. Actually, you'll be seeing here artery also. So you can see I'll be freezing here. So this is the long axis view of the biceps tendon getting attached with the radial tubercle. So you can see this is the radial head, this is the neck of radius, and this is the radial tubercle. And you can see a long axis view of the biceps tendon getting attached with the radial tubercle. So this was a long axis view, and this one is the short axis view. Okay, so this here you can see nicely see the short axis view of the biceps. So here, so this one is the long axis view of the biceps tendon getting attached with the radial tubercle. You can nicely appreciate radius, and this one is the short axis view of the biceps tendon. Okay, so now coming to the more important part, that is the medial aspect or lateral aspect of the elbow joint. Okay, so in the lateral aspect of the elbow joint, I told you there are all the extensor muscle, basically. So all the extensor muscle of the hand, okay, it basically comes here and forms the common extensor tendon and gets attached to the lateral epicondyle. You can easily palpate the bony tubercle or bony protuberance in the lateral aspect of the elbow joint. So this is the lateral epicondyle. If you just put your probe over the lateral epicondyle, you will get the image like this, okay, like shown in the ultrasound. Let's decrease the depth. So if you remember, look at my position of the probe. My probe position is along the long axis of the extensor muscle. So extensor muscle will come like this and goes to the hand. So my probe positioning is along the long axis of the extensor muscle. So if you just slide your probe more proximally and towards the bump here, so this one is the. So now we can very nicely see the common extensor tendon. So these are the muscle, okay, common extensor muscle. So it is all going towards this one is the radial head, okay. Above this one is the joint, radiocapitular joint, and above the joint there is a slope, like bony prominence and slope is there. So this is the lateral epicondyle, where the attachment of the, okay, I'll be freezing here. So in this picture you can very clearly see. So this one, the bony structure is a lateral epicondyle. This is the distal part of the humerus, and you can see this is the radius. This is the joint, okay. But above the joint, you can see this is the myotendinous junction, and tendon is coming and getting attached. So this is the attachment of the common extensor tendon. Right? Okay, so this is the commonest site of the lateral elbow pain, which is known as the tennis elbow. So if you divide this slope. If you divide this slope in the upper 2/3 and lower 1/3, okay? So upper 2/3 is basically attachment of the common extensor tendon, and lower 1/3 is basically attachment of the radial collateral ligament, okay? So here, so if you divide this slope into upper 2/3 and lower 1/3, so all these fiber getting attached here. So these are the common extensor tendon, okay, and this lower part is the lateral ligamental complex or radial collateral ligament. So if you see any tear or partial or a full thickness tear here, you can easily put a needle like this, okay, and you can do multiple puncture of this tendon. So this is called tenotomy. So if you basically multiple puncture this tendon multiple times, then we are creating an injury, and injury is usually followed by healing. So we are promoting neovascularization here and basically promoting healing of this tendon. And then we can also put a needle directly here under the in-plane needling is there, and wherever is there, we can inject PRP. About 0.5 to 1 ml of PRP can be injected wherever the tear is in case of tennis elbow. Okay, and basically there are these common extensor tendon basically consist of 4 different tendon. First one is extensor carpi radialis brevis. Another is extensor digitorum. Another is extensor digiti minimi, and finally is so these are the 4 tendon. Extensor carpi radialis longus does not take part in formation of this common extensor tendon. Okay, it starts with extensor carpi radialis brevis. Okay, then comes extensor indicis, extensor digitorum, and in the extensor digiti minimi, and extensor carpi ulnaris. So these are the 4 tendon which forms the common extensor tendon and gets attached to the lateral slope of the lateral epicondyle. Okay, and this whole portion is the common extensor tendon, and lower portion, this one is the radial collateral ligament. Okay, similar to that, basically if you scan the medial part of the, if you just palpate the medial aspect of the elbow joint, and if you put your probe right over here, right over the medial epicondyle, you can, similar to the lateral side, you can also see another slope. Okay, so this slope is basically, if I freeze here, see the position of my see the position of my probe. So I'm putting my probe along the long axis of the flexor muscle, just over the medial epicondyle. So you will be getting this kind of picture. And if you see here also, if you divide this slope, upper two-third is basically attachment of common flexor tendon. Okay, so common flexor tendon, and lower one-third is basically attachment of the this ulnar collateral ligament. So lower one-third is ulnar collateral ligament, upper two-third is this tendon. There is a bird beak-like attachment of this tendon. Okay, this is the common flexor tendon. So in common flexor tendon, there are actually 5 tendons. Okay, so there are 5 tendons. First one is pronator teres. First, second one is flexor. This is flexor, no? Flexor carpi radialis. Then palmaris longus is there. Third, fourth one is flexor carpi ulnaris, and fifth one is flexor digitorum superficialis. Okay, these 5 tendon, basically these 5 tendon, pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris, and flexor digitorum superficialis. These 5 tendon basically merges together to form a common tendon, and it is getting attached like a bird beak manner at the medial epicondyle. So this is medial epicondyle. So if there is a tear here, this can commonly give rise to the golfer's elbow. And in case of golfer elbow, you can also, like in tennis elbow, you can also inject in plane, you can inject PRP within the tendon. And you can also do multiple fenestration of this tendon to promote healing. Okay, so this is the medial side, and that one was the lateral side. Okay, so coming to the posterior side of the elbow joint. So posterior side of the elbow joint can be examined like this. Like, see how the patient is putting his hand like this, posterior part of the elbow joint. Okay, like this. So see the position of the patient. He's putting his palm like this. Okay, and he's doing like, okay. If this is just palpate the medial epicondyle and the olecranon process. So there are 2 processes. One is, this one is the medial epicondyle. So it is going in the medial aspect of the hand, and this prominence is the olecranon process. So if you put your probe right over like this, you can nicely see my marker. Okay, so sorry for that. Like this. Okay, my marker is in the left side. Okay, so if you, this one is a cubital tunnel. I have put my marker, one end of the footprint is over the medial epicondyle, another end of the footprint is over the olecranon process. So if I just put like this, you can see very nicely, you can see the ulnar nerve. This one is the, so if I freeze this, so here you can see this one is the medial epicondyle, and this is the elbow joint. Okay, here this one is the ulnar nerve. Okay, this one is ulnar nerve in the cubital tunnel. Okay, so if you see, this one is the medial epicondyle. Ulnar nerve will be closely associated with the medial epicondyle, and this is the olecranon process. Okay, and there is one ligament above and one ligament below. So above ligament is the os ligament, and below ligament is basically a part of posterior band of the medial ligamental complex. So this is the cubital fossa. So here entrapment of the ulnar nerve can happen. So if it happens, you can see enlarged swollen ulnar nerve. In this condition, we can inject local and steroid around the ulnar nerve to take care of the cubital tunnel syndrome. You can see nicely, you can see the ligament. This is the os ligament, and below also there is one ligament like this. So this ligament joining the medial epicondyle and the olecranon process is the posterior band of the medial ligamental complex. So this is the ulnar nerve. Okay. So in the posterior elbow, there is another structure that is of importance, is the olecranon bursa. Okay, olecranon bursa is also very common clinical presentation. So here, to identify olecranon bursa, first let's see. So here, look at my probe position. Patient is sitting like this. He is doing 90-degree flexion of the elbow joint. So if I put my probe just over here, distal end of this one, the big muscle, chunk muscle that you are seeing is basically a triceps muscle. Okay, this one is the triceps muscle. Okay, and the left side of the screen is the medial side. This one is the medial side. So if I freeze it over here, okay. So, so here, so I'm putting my probe in a horizontal manner just at the distal end of the humerus, okay, in the posterior side of the elbow. So here you can see few structures. So this muscle that you are seeing is a triceps muscle. This one is triceps muscle. Okay, this entire muscle is the triceps muscle. This entire muscle is the triceps muscle. It is called triceps because it has 3 head, 1, 2, 3 head. Okay, so it is called triceps because it has 3 head. So this one is 1 head, this one is another head, and this one is another lower part is another head. So this one is the medial side, and this one is the lateral side. Okay, so and this one is the central tendon. So below is the medial head is in the below. Most deeper structure is the medial head. Okay, lateral part is the lateral head. Medial side is the long head, and this one is central tendon. So this one is the central tendon, and in the medial side there is a long head of the triceps, and in the lateral side there is a lateral head of triceps, and below the lateral head, long head, and the central tendon is the medial head of the triceps. So because it has 3 heads, it is called triceps. Okay, so this is the short axis view of the triceps muscle. So now, after seeing the short axis view of the triceps muscle, let us rotate the probe 90-degree and try to see. Okay, so here in this picture you can see very nicely. You can see these are the muscle of the triceps in the long axis view, and all these muscles are basically, it forms the tendon and it gets attached to the superior surface of the olecranon process. So this one is the superior surface of the olecranon process. And look, initially I was scanning like this, short axis view of the triceps muscle. Now I'm rotating this 90-degree. I'm trying to see the triceps in a long axis view. So this is the triceps in a long axis. Okay, now I'm basically freezing. I'll be freezing here. Okay, so here you can see. So this one is the central tendon, and this one is the medial head of the triceps. This one is central tendon. So medial head, all the central tendon is going and attaching to the, this one is olecranon process. Okay, so this one is the olecranon process of ulna, and this one is the distal end of the posterior part of the humerus. This fossa is known as olecranon fossa, because this olecranon head will come into this fossa when the hand is fully extended. And this one is the joint. Okay, this one is the, so this one is basically a joint between the ulna and the distal end of the humerus. And this fossa is olecranon fossa. This is filled up with fat pad. Okay, fat pad. And this muscle is all coming here and it is getting attached to the superior surface of the posterior part of the olecranon process. So this is the attachment of triceps. You can appreciate olecranon bursitis over the in the subcutaneous plane above the tendon of the triceps. So if you want, so if the patient comes with a posterior elbow pain, so this might be, if this is the normal location of the olecranon bursitis above the triceps tendon. Okay, not below the triceps tendon. So this is the triceps tendon getting like a bird beak attaching, getting to the olecranon process. Okay, so this is the olecranon. So this is the location of the, here is the location of the olecranon bursitis. And if you see olecranon bursitis, you can nicely inject in the olecranon bursa local and steroid. Okay, So these are the main structures that we are seeing in the elbow. Posterior elbow, we have to identify the olecranon bursitis, area of the olecranon bursitis, as well as localization of the elbow joint from behind. Okay. In the lateral aspect, the most important structure is the tennis elbow, where you can you will be seeing all the flexor extensor muscle getting attached. So normal position is like this. You tell the patient to lift the thumb. So if you do this, extensor carpi radialis longus will be outside. Okay, now what you'll do is you put your ultrasound beam along the long axis of the extensor tendon and palpate the lateral epicondyle. You put your footprint, one end of the footprint over the lateral epicondyle. So this is the common extensor tendon, right, getting very nicely attached with the this one common extensor tendon getting attached with the lateral epicondyle. Okay, so this is the common site for the tennis elbow. Now coming to the medial side, it is very much similar. Okay, medial side, palpate the medial epicondyle. So you palpate the medial epicondyle like this, and you put your probe over the medial epicondyle. Okay, and along the long axis of the flexor group of muscle, you can very nicely see the common flexor tendon getting attached to the. This is the medial epicondyle, and you can see very nicely common flexor tendon getting attached with the slope of the medial epicondyle. Okay, so and in the posterior aspect, in the anterior aspect, you have to know how to identify this home page. Whenever you are lost, you have to come to this home page. Okay, so home page, I'm again repeating. So just put your probe over the crease of the elbow joint, and you can nicely see the wavy structure. So this is our home page. Actually, we are seeing the distal end of the humerus, and above the distal end of the humerus, there is two muscle. Big muscle is brachialis. This big muscle is the brachialis muscle. Okay, big muscle is the brachialis muscle, and above the brachialis, at the summit of this hill, is the biceps short is the tendon, short axis of the biceps tendon. In the lateral aspect, you can see brachioradialis muscle, and between brachioradialis and brachialis, you can see the radial artery, the radial nerve. Between the brachialis and brachioradialis in the lateral aspect. Okay, and in the medial aspect, you can, if you glide your probe medially to this home page, you can nicely see the median brachial artery. You can see brachial artery. So you can see nicely brachial artery. Medial to the brachial artery is this, the medial to the brachial artery, you can very nicely see honeycomb-like structure. That is a median nerve. It is basically located between the pronator teres and brachialis muscle. Okay, so these are the structures that you will be seeing in the ultrasound. And one more structure I'll be showing you is the elbow joint from above. Okay, from front. So here I'm trying to show you the elbow joint from front. So if you put your probe like this, here the left side is the cranial side. The left side of the screen is cranial side, and the right side of the screen is in the caudal side or the distal end. You can see very nicely the elbow joint. Okay, this is the radiocapitular joint. Look at my probe position. It is along the long axis of the humerus. Okay, in the lateral side, if you put like this, you can very nicely see head of the radius articulating with the capitulum of the humerus, forming a radiocapitular joint. So here, this one is the elbow joint from in front. So this one is the head of the radius. Okay, and this one rounded structure is the capitulum, and this one is the capsule, articular capsule, and you can inject into the radiocapitular joint by this approach. Your needle will be like this, and you will be piercing the capsule and going into the radiocapitular joint. Okay, so this one is this one is in the lateral aspect, and in the medial aspect, if you glide your probe medially Okay. So here, sorry for that. So here, if I glide my probe medially, you can see I'm putting my probe, I'm putting my, yes, sir. So you can see I'm putting my probe along the long axis of the humerus in the medial side of the elbow. So when I do this, you can very nicely see the ulno-humeral joint. So this one is an ulno-humeral joint. Okay, in the medial aspect. Okay, this one is ulno-humeral joint. And if you want to inject in the ulno-humeral joint, your needle will be coming like this, and you'll be piercing this capsule and getting injecting. In this one is the coronoid process of ulna, and this is the trochlea of the humerus. So this joint is called ulno-humeral joint or a humero-ulnar joint. You can call it either of these. Okay, but main thing is this one is articular capsule, and your needle is coming like this, piercing the capsule and going to the ulno-humeral joint. Okay, so this is all regarding the elbow joint. If you want me to show any of the structure in the elbow joint, I can repeat this. Anybody wants to repeat any of the structures of the elbow joint?
Sir, in long axis view of the anterior elbow, beneath the insertion of the biceps tendon, the muscle, sir. Which muscle?
It is inserting to the radial tubercle. There is a below is a brachialis. So you are talking about this one. Okay, I'll remove this. Okay, so this is the home page. Okay, if I do the long axis view, I'll 1 minute. Okay, I'll put some jelly here. Let's put some nice jelly. So here the cranial part is the. Okay, sorry for that. Okay, so this is the distal end. You can see the lower muscle is the brachialis muscle, and the upper one is tendon of biceps. Okay, you are talking about this view, no?
Yes, sir.
Okay, so I'll freeze this. Okay, let's see. Okay, I'll freeze this. Let's make it more nice. Okay. Okay. So this is. Are you talking about this view? So this
Yes.
one is the tendon of the. This one is radial head getting attached. This muscle is brachialis muscle. Okay, and this one is the biceps tendon. So this is the the biceps tendon getting attached with the radial tubercle. Below to this is the brachialis muscle. So it is similar to this. Okay, look here also. Here also, in this picture also you can see below the biceps is the brachialis muscle. This one is brachialis muscle. In the home page, you can nicely see. In the home page, you can see. So this is the biceps. Okay, this tendon is the biceps tendon in short axis. Below the biceps tendon is the brachialis is the muscle. Okay, this one is the brachialis muscle, and this one is the biceps tendon. Okay, below the biceps tendon is brachialis muscle.
Got it, sir.
So I'm showing you in both view. Okay, now so if you so this is in both long axis and short axis view. Okay, so that you can correlate very nicely. Okay, so here I have included both long axis view and short axis view. Okay, so for that you will be more clear. So this is a short axis view and this is the long axis view. In the short axis view, you can see biceps above and below this brachialis. Okay, this one is biceps. In the long axis view, you can also see biceps above getting attached, and below this is the brachialis muscle. Okay.
Yes, sir. Thank you, sir.
Okay. So any other doubts in the elbow joint? No? Okay, let's go to the wrist now. Okay. We are basically examining wrist from the anterior aspect. From the posterior, we are seeing the dorsal compartment. We are also seeing the medial aspect, one of the first compartment of the dorsal aspect. Okay, and we'll be also seeing in the anterior side how to scan the median nerve, and we'll be seeing the pulleys in the finger. Okay, so let's start with the most common one. That is the carpal tunnel and the median nerve. Okay. So basically, if you want to scan the carpal tunnel, you can put one roll over here, and you can extend the elbows, wrist joint like this. Okay, put a roll over here below the elbow, below the wrist, and put your hand so that the wrist is flexed, extended. Okay, and you put your marker or your this one is the linear probe just over the lower part of the forearm. Okay, once you put your probe in the lower part of the forearm, you can see few structures. So actually, this is our home page. Okay, so you start your scan from the lower part of the forearm. If you want to scan the median nerve, start not directly from here. Okay, start from the lower end of the forearm. And as you can see, there are a few structures you can very nicely see. Okay, in this picture, if I freeze this, okay, if you freeze this, basically the structures that you are seeing is this one is the radius. Okay, this one is the radial bone, and this one is the ulnar bone, and it is the inferior radioulnar joint. Okay, this one is the inferior radioulnar joint between the radius ulnus, and this flat muscle I was talking about is the pronator pronator quadratus. So this is the home page, and above the pronator quadratus are various other flexor tendons. Okay, these are the flexor tendon. Okay, so this is our home page. One hyperechoic structure is the radius. Another small hyperechoic structure is the ulna. Above this flat muscle is pronator quadratus muscle. So this is our home page. We usually start from here. Okay, so after getting this view, so this is the left side of the screen is the radial side, and the right side of the screen is in the ulnar side. Okay, so after getting this home page, after getting this good pronator quadratus, I'll basically glide my probe downward. Look, first thing that is vanishing is you can see here one structure, this structure will vanish. This is ulnar. So as I've told you in class, ulnar doesn't take part in forming the wrist joint. Look, as I move my probe, glide my probe more distally, slowly the ulna will vanish. Look, ulna is vanishing. Only radius is remaining. Okay. Now, if I glide my probe more down, you can see another hyperechoic bone is coming here. This one is lunate. Okay. So this one is lunate. But starting from here, this was our home page, the lower part of the forearm. So I'm not starting from the crease of the wrist. Okay. I'm starting about 1 inch above the wrist crease. I'm putting like this. So this is our home page. So you should nicely see two hyperechoic structure. One radius, very nicely seen. Another is ulna. Above it, the flat muscle is pronator quadratus. Okay. So after getting this, slightly glide your probe more distally, and you can appreciate ulna is getting lost. So it is getting vanished because it doesn't take part in wrist joint. Now, if I come more down, then another hyperechoic structure is coming from here. Okay, focus here. Okay, so another hyperechoic structure is coming here. So this one is lunate. And lateral to the lunate is basically scaphoid. Okay, so scaphoid and lunate you can nicely see. Okay, and this is the area where you are seeing the carpal tunnel. So here you can see, once you get this one is lunate, first bone is lunate, and lateral to this is the scaphoid, and this one is lunate. First carpal bone that is seen in ultrasound is lunate. Okay, so once I get this, again slide down. Now you'll appreciate two hyperechoic structure. Okay, so now you'll be appreciating two hyperechoic structure. This one hyperechoic structure, this is another hyperechoic structure. So this one is a medial side, and this one is in the lateral side or radial side. So this is what is this? This is the scaphoid bone, and this is pisiform bone. So these are the two carpal bone that is seen in ultrasound. Okay, first. So this is like a lion guarding the temple. You can see two hyperechoic structure. One in the medial side is the pisiform, and the lateral side is the scaphoid. Okay, and if I freeze here, you can see a small like band-like structure extending from the scaphoid to pisiform. Okay, this one is the flexor retinaculum, which extend from one heel to another heel. So this one is pisiform, this is scaphoid because this is the radial side and this is ulnar side. Okay, so basically what happens is there is one fibrous extension, ligamentous extension, creasing between the arising from scaphoid and going towards the pisiform. And as it goes to the pisiform, it basically bifurcates like this. And the upper one is called transverse carpal ligament. Okay, and the lower one is basically a part of flexor retinaculum. And here will be the ulnar nerve. And this is Guyon's canal, where there is ulnar nerve and ulnar artery. Okay, so this is I'll be demonstrating you very nicely. Pisiform, scaphoid, pisiform, flexor retinaculum dividing into two, incorporating ulnar nerve and ulnar artery. Let's see this very nicely now. And you can see below this will be the median nerve, and there will be 9 tendons will be here. Okay, so let's start this scan. Okay, I'm again starting from home page. I'm starting from home page. Okay, once I get this, come below, see the distal end of the radius. Now lunate is coming in the center of the screen. Lunate. Now if I come more down, now you will see two more bone on either side. So this is in the lateral side is the pisiform, and in the medial side is the lateral side is a scaphoid, and medial side is pisiform. So if I tilt my probe, look what I'm doing after reaching here. So this is basically anisotrophy. So if I tilt my probe like this, you can see very nicely, you can see lots of tendon, and you can also see the median nerve. Okay, so here, this is how. So you can see here. Okay. Okay, so this is basically I'm freezing here. Okay, so this is basically a proximal carpal tunnel, where you can see nicely this is a scaphoid, this is pisiform, and you can see a band-like structure here extending like this. Okay, so this one is the flexor retinaculum, and this just below the flexor retinaculum is the median nerve, and these are the various 9 tendons. So these are the tendons. Okay, So again, so this is the median nerve, which is below the flexor retinaculum. Okay, and this one, this is the ulnar artery. Here is the ulnar nerve, and these are the flexor tendon. 4 flexor digitorum superficialis, 4 flexor digitorum profundus, and 1 is flexor pollicis longus. So there are 9 tendons. Above is flexor digitorum superficialis. Below row is flexor digitorum profundus, and in the lateral side there is a flexor pollicis longus, and this one is the median nerve. So the content of carpal tunnel is basically the median nerve, main, and the 9 different tendon, and these are basically the capitate. These are basically the hyperechoic structure, are basically the carpal bone. Okay, so how to identify the nerve with tendon? So there is basically, you might get confused which one is nerve and which one are the tendon. So how to differentiate between nerve and tendon? So first thing you should remember is nerve. If you see this here, if you see this, this is the picture. Okay, so if you see this, how to identify which one is nerve and which one is tendon? So to identify this, what you have to do is you have to tilt the probe like this. Okay, so if the tendon are more anisotrophic, so if I basically move probe like this or toggle my probe like this, everything will be black and white. So this is anisotrophy. But if you see in the nerve, the anisotrophy effect is very less. In tendon, the anisotrophic effect is very nice. Okay, so if these are the tendon and the nerve, so if this is the tendon, if this is the carpal tunnel, so if you appreciate, if I move my probe like this, you can see various hyperechoic tendon as well as nerve. But if I tilt my probe like the tilt my probe or angulate my probe, the anisotrophic effect of the tendon, which will be much more than the anisotrophic effect in the nerve. That means the nerve is black, whether if I tilt like this or that, like this. Okay, but you can see the anisotrophic effect on the tendon will change. This is one of the trick. Another trick is tell the patient to move his hand, move the finger. Okay, if the pain, yeah, can you see the tendon? All tendons are moving very vigorously, but the median nerve is not moving that much. Okay, so this is another trick. So tell the patient to move their finger. Okay, so can you see all the tendon are moving very nicely, but the nerve, the median nerve is remaining where it is. Okay, so I will show you in my picture. Okay, so in my the median nerve is very nicely seen. Okay, so this upper one hyperechoic structure is median nerve. Okay, so if I do like this, tilt my probe like this, median nerve is still black and the tendons are all black. But if you tilt like this, look, all the tendons can be very nicely seen. And nerve is
Sir,
also,
point out the median nerve, no? Point
so
out the median nerve.
nerve is just below on the top of the screen, just below the yellow marker. Can you see a yellow mark there?
Yes, sir.
Can you freeze? Actually, freeze my feasible. Oh, okay. So this is in my volunteer median nerve was not that great. So I'm showing in my own. Okay. So this one is median nerve.
Okay,
So
sir.
this is the flexor retinaculum, and these are all tendon. Okay. See how it changes. Okay. See this hypoechoic structure, honeycomb-like structure, hypoechoic structure below the flexor retinaculum is the median nerve, and these are all tendons. So how to identify which one is tendon and which one is nerve? So there are 3 tricks. Okay. First trick is after getting, I'm doing in my own because I've put a very good median nerve. Okay, so you can see now, we can very nicely see median nerve at the center of the screen. Okay, so here you can see the left side is in the medial side and the right side of the screen is in the lateral side, radial side. The left side of the screen is the left side of the screen is the ulnar side, and the right side of the screen is the radial side, okay? So you can see pisiform, you can also see, okay? So how to identify? Can you identify the median nerve now? On the top hypoechoic structure, just below the yellow mark. Can you see median nerve?
Yes. Yes, sir.
Okay, how do I look? If I tilt my probe like this, look, median nerve is still black, but all the tendon are all more blacker. Okay, this is anisotrophy. If I tilt like this, you can see nicely tendon is hyperechoic. So this is the anisotrophic effect. In the nerve, anisotrophic effect is very less. So it is black. If I do tilt my probe like this, or if I angulate my probe, look, the nerve ultrasound picture will change very less. But if you can see the tendon, you can see the tendon. I'm moving my finger. You can see all the tendon moving very nicely. So tendon, if you tell the patient to move the fingers, you can see tendon will move very right and left very vigorously. But the nerve will not move that much. Okay, that is one of the trick. Another trick is angulate the probe like this, okay? Cranially and caudally. See the change in the anisotrophy of the tendon. Tendon is white here. Okay, now it is black, but the nerve is black. Whether I tilt my probe right or left, if I tilt my probe, can you see the difference between nerve and tendon? Very nicely seen. Yes?
Yes,
No?
sir.
Okay, look.
Yes, sir.
Nerve is very nicely seen. All the tendon are lost. Okay, because anisotrophy effect in the nerve is very less. But if I tilt my probe like this, you can very nicely see hyperechoic tendon, and you can also appreciate, tell the patient to move the finger. You can see tendons are moving very nicely, but the nerve, this nerve in the top is remaining. It is same. It is not moving that much, but the tendon are moving very much. Another way is to trace the median nerve up. Okay, if I trace the median nerve more proximally, you can see, look how you can see median nerve coming down, coming down, coming down, coming down. You can see median nerve now between. Can you freeze here? Please, God. Okay, so this is the median nerve. Okay, if you just focus this median nerve, see how it comes up and on freeze. God. So if you see this, look how it comes up. You just trace that. It does speak material. Yeah. See how it comes up. It was now between the flexor digitorum superficialis and profundus. But if I'm moving my probe towards the finger, look how it comes up. Can you appreciate? Nerve is coming up. Honeycomb-like structure in the center is the median nerve. Can you appreciate this? Yes?
Yes, sir.
Okay.
Sir.
See, okay? Just trace that. See that. Okay. It is coming more superficial. It is coming more up. It is coming more up. Now it is coming in the carpal tunnel. Can you see? Now it is coming in the top of the carpal tunnel. So this is the median nerve. This is one way to identify median nerve. And then another way is to angulate the probe cranially and caudally. See the anisotrophic effect in the tendon and nerve. The anisotrophic effect in the nerve is less, but anisotrophic effect in the tendon in the nerve is less, but in tendon it is more. And tell the patient to move the finger. See how the tendon are moving right and left, but the nerve is not moving that much. Can you appreciate in the center? Yes?
Yes, sir.
Oh, this is the three-way. Look how the median nerve dips in down. Okay, look, and it remains between the flexor digitorum superficialis and profundus. So these are the three tricks to identify the median nerve. And median nerve can be also seen in the long axis view. Okay, so let's see median nerve in the long axis view. So okay, so this was left side is the medial side and the right side of the screen is in the lateral side. Okay, and you can see very nicely median nerve just below the yellow marker. Okay, so this is the short axis view. But if I rotate my probe like this, you can see the long axis view of the median nerve. Okay, can you appreciate the hypoechoic structure This is the long axis view of the median nerve. Freeze कर दूँ So this is the long axis, unfreeze कर दूँ unfreeze. And this is the short axis view of the median nerve. Freeze कर दूँ Okay. So in the right side of your screen is the short axis view of the median nerve. And this one is the long axis. You can see this one is the median nerve. Upper hypoechoic is the median nerve, and below one is the flexor digitorum superficialis tendon. So this is the flexor digitorum superficialis tendon, and this upper one is the median nerve in the long axis. Okay, and this one is the short axis of the median nerve. Actually, you can measure the median nerve. Okay, and say whether there is a carpal tunnel or not. So this is the. I'll show you how to measure this, okay? And because you have to measure the diameter of the median nerve. Okay, look, can you freeze? Okay, so here you can very nicely see this one is the ulnar artery. Okay, so this must be pisiform. Okay, and this one is the scaphoid. So from the scaphoid, you can see an arch-like structure extending like this. Okay, so this one is the flexor retinaculum, and it basically divides like this. And okay, so here you can see this one is the median nerve, and these all other structure are basically the tendons. There are 9 tendons. Okay, these are the median nerve. Now you have to measure the cross-section area of this measure. You have to measure the cross-section area of the median nerve. If cross-section area is above 13, above 10, it is suggestive of carpal tunnel syndrome. If it is above 15, it is a diagnostic of carpal tunnel syndrome. So you measure the cross-section area in the millimeter square. So what you do is, in the ultrasound machine, there will be a 1 minute, okay? There will be in the ultrasound machine, okay? So in the machine, there will be a measurement. Can you see? In this one is the measurement. I'm using the measurement now. So in the measurement, you can either do 2 things. One is ellipse formula. You can put here, and you can put your marker like this, okay? Like this, and you can just measure the median nerve like this. So this is one of the way to measure the median nerve, and this is by ellipse formula. There is a preset in your ultrasound machine. You can use that, and you can see cross-section area. Look, the cross-section area is here is. Can you see the cross-section area? It is 16 centimeter square, 0.16 in this area. Can you see the measurement cross-section area? It is 16 centimeter square, 0.16 centimeter square.
Yes,
Okay,
sir.
that I have a carpal tunnel syndrome. I do have a carpal tunnel syndrome. That's why I'm showing you in my own picture. Okay, so this is basically a diagnostic for carpal tunnel syndrome. You can measure like this ellipse formula, or what you can do is you can also use another formula. Okay, you can also trace the area. So there is another feature here where you can trace the entire median nerve. Okay, and this is another way to get the cross-section area. So here also you will be area, look, cross-section area. These are the 2 methods to basically see the cross-section, measure the cross-section area of the median nerve. One is ellipse formula. Okay, one is ellipse formula, and another is basically the trace the median nerve. I'll show you once again. Okay, so I'm first using ellipse formula. Just go to the measurement, put the ellipse preset value ellipse, and then put your marker like that, one end of the median nerve. Okay, double tap here, and this like round structure will come, and again decrease this structure from above. like this. So this is the tentative cross-section area of the median nerve, and it shows around. This is how you measure, okay? It shows around how much it shows. It is about 18 millimeters square, okay? This is one of the diagnostic for carpal tunnel syndrome. Another measurement is basically go to the preset value, see the area tracing. So there will be a area tracing function here. Just trace the entire circumference of the median nerve like this, like how I am pressing. Okay, so this is the two-way how to measure the and see the cross section area. It is nicely shown that it is 18 millimeters square. So these are the two methods of seeing the identifying the median nerve and measuring the cross section area of the median nerve. So if the value is more than 10 or more than 10, it is basically a diagnostic. And if the value is more than 15 millimeters square, then it is confirmatory for the carpal tunnel syndrome. Okay, so let us see now. Now from the anterior aspect. Now let us first see the posterior part of the wrist joint. Okay, the posterior part of the wrist joint, we are basically concerned with the various compartment, that is dorsal compartment. So in the posterior part of the wrist, basically we are concerned with the dorsal compartment. Okay, so here, see, this is the dorsal aspect of the wrist. If you put your marker just over the dorsal aspect of the wrist, just palpate here first, palpate here in the distal aspect of the radius, there will be one tubercle. You can easily feel there is one bump in the distal aspect of the radius. So this bump is known as Lister's tubercle. This is seen in ultrasound as a bony prominence. Okay. So here I am scanning the dorsal aspect of the wrist. You can see the left side of the screen is basically the lateral side, medial side, and the right side of the screen is the radial side or the lateral side. Left side of the screen is medial side or ulnar side. Right side of the screen is basically the radial side or the lateral side. Here in the center, can you see a hill-like projection in the center? This. Can you see a hill-like elevation? So this is called Lister's tubercle. Actually, you can very nicely palpate the Lister tubercle in the distal end of the dorsal aspect of the radius. Okay, you just put your probe like this. So basically, what does this Lister's tubercle does is it divides compartment number 2 from compartment number 3. Okay, so if you come to the radial side, then this is compartment number 2, where you can see nicely two tendon, extensor carpi radialis longus and extensor carpi radialis. So this is the Lister tubercle. Okay, so this one is Lister's tubercle, and this is compartment number 3, and this is compartment number 2. Okay, so if we go more to the radial side, you can appreciate, you can see, first identify the Lister tubercle. Okay, this bony prominence, then come to the radial side. You are seeing two different tendon here. This is compartment number 2. That means extensor carpi radialis longus and extensor carpi radialis brevis. If I glide my probe or slide my probe more to the radial side, this is the compartment number 1. Okay, here you will see two tendon. One is abductor pollicis longus and another is extensor pollicis brevis. So this is compartment number 1. This one. So here you can see decubitant Tenosynovitis. Many patients will complain of pain in the lateral aspect of the wrist. So this one is compartment number 1. Here you can nicely see one abductor pollicis longus and extensor pollicis brevis. Okay, this is compartment number 1. So if I go to the radial side, now you will see two different tendon. So this is compartment number 2. That is extensor carpi radialis longus and extensor carpi radialis brevis. Okay, this two tendon. Now comes the Lister's tubercle. Now comes the Lister's tubercle. Because this is Lister's tubercle, the hyperequation. Now, medial to the Lister's tubercle is compartment number 3. So this one is compartment number 3. So this is Lister's tubercle. Lister's tubercle. This is compartment number 3. So this means that is there is a this is extensor pollicis longus, and this one is compartment number 4, and this one is compartment number 5. Okay, and here will be compartment number 6, extensor carpi ulnaris. Okay, so this one is compartment number 6. So I'll scan all the compartment. Okay, it is very difficult to show all the compartment. First, identify the Lister's tubercle, bony landmark. Okay, at the middle of the screen where there is yellow dotted line. So if you go to the radial side, the first 2 tendon that you are seeing is the compartment number 2. That is extensor carpi radialis longus and extensor carpi radialis brevis. If you come more to the radial side, you can also see 2 tendon very nicely seen. Okay, look, can you see, appreciate 2 tendon? Yes?
Longus brevis, longus brevis.
Longus brevis. Yes, this is 2 tendon. This is the abductor pollicis longus. First one is abductor pollicis longus, and another one is extensor pollicis brevis. So this is compartment number 1. So here you can have tenosynovitis of a compartment number 1, known as decuberance tenosynovitis. Okay, so this is compartment number 1. Let's go back again. So from compartment number 1, if I glide my probe more to the ulnar side, you will be getting the second compartment, that is extensor carpi radialis longus and brevis. So if I go more medially, there comes the Lister's tubercle. Okay, this basically divides compartment number 2 and 3. Lateral or medial to the compartment number 2 is here. Okay, so I'm going to freeze here. So here, so suppose this is Lister's tubercle. This is compartment number 2. Okay, this is compartment number 3. A small muscle, just one tendon, that is extensor pollicis longus. And this one is compartment number 4, where there are 5 tendons. It is extensor digitorum and extensor indices. And this one is compartment number 5. There is only one tendon, that is extensor digiti minimi. And here will is the compartment number 6, that is extensor carpi
ulnaris.
So this one is extensor digiti minimi. Okay, the 4th compartment consists of 2 different things. One is extensor digitorium and one extensor indices. So there are 5 tendons. 4 is extensor digitorium and 1 is extensor indices in this compartment number 4. And this in compartment number 3, it is
Longus.
longus, only one. And this is tubercle. Okay, so lateral to the Lister's tubercle, there are 2 tendons. One is extensor carpi radialis longus and another one is extensor carpi radialis brevis. Okay, can you see 2 different tendons here? Second compartment. So this is Lister's tubercle. Okay, this one is 3rd compartment, only one. So this whole part is the 4th compartment. Here there are 5 tendons. Okay, so this one is compartment number 5 and this one is compartment number 6. 6, 5, 4, 3, and then comes the Lister's tubercle and compartment number 2, and here will be compartment number 1. Okay, our main clinical importance is this area, compartment number 1, where there is decuberance tenosynovitis is there. So this is how you identify the various compartment. But for our clinical significance, compartment number 1 is the most important, followed by compartment number 2 and 3, where there is intersection syndrome, which I will not be discussing right now. In the advanced class, this will be demonstrated. Okay, so once again, I'm showing this compartment, various compartment. Okay, so first put your probe, palpate the Lister's tubercle in the dorsal aspect of the radial radius, distal end. Put your probe right over it, and you can see a mountain-like structure there, hill-like structure there. So it basically divides compartment number 2. This one is compartment number 2 in the radial side. Extensor carpi radialis longus and brevis. If I move lateral on the next and the other side of the Lister's tubercle, this is compartment number 3. You can see one tendon is there, compartment number 3. If I go more lateral, you can see compartment number 4, very nicely seen, compartment number 4. And this one is compartment number 5. And if I go more laterally, this one is compartment number 6. Okay, so this is how you identify compartment, various compartments. So here the clinical significance is Lister tubercle, compartment number 2, and go more towards the thumb. So you can see very nicely 2 tendon. This is abductor pollicis longus and extensor pollicis brevis. Okay, so this is of clinical importance where there is decubital tenosynovitis, where you can inject, your needle can come here like this, like this. Sorry. So where your needle can come like this and inject around the tendon, around, not into the tendon, but around the tendon. Fluid surrounding the tendon, steroid. You can inject steroid here. Okay. So are you clear regarding this compartment?
Yes, sir.
Very nicely seen. Okay, look. Compartment number 3, 4, and 5. Very nicely seen. Look, very nicely seen. This above the joint is always compartment number 5. Okay. Above the radio-ulnar joint is always compartment number 5. And can you see the subject is moving his finger? That is compartment number 4. Can you appreciate tendon moving in compartment number 4? Focus here.
Yes, yes, sir.
That is extensor digiti, extensor digitorium, and extensor indicis. Okay. If I come more towards the Lister tubercle, you can appreciate the compartment number 3. That is extensor pollicis longus. So this area is extensor pollicis longus, and this one is more towards the radial side is the compartment number 2, extensor carpi radialis longus and brevis. If I go more to the radial side, you can see this one is compartment number 1, where there is abductor pollicis longus and extensor pollicis brevis. Okay, so this one you have to know in the lateral compartment. Now coming to the one more structure that if you want. So let's see the superficial radial nerve. Okay, so this structure in the center, can you see 2 hypoechoic structure in the center of my screen? Can you see 2 black structure? Yes.
Yes, sir.
So in the center of the screen, you can see 2 structures here. 2 black spots are here. So here, this one is the cephalic vein, and this one is the superficial radial nerve. The smaller one is superficial radial nerve, and the big one is the vein. Okay, you can see as I move my cranial and caudally, this superficial radial nerve will come below the vein. Okay, let's appreciate this. Okay, so the left side of the screen is the, can you appreciate, can you see black structure? 2 black structure are there in the center of my screen. So if I move like this, can you see one black line will be coming below this? Can you see it is crossing it in the center? In the center, you have to put lots of jelly because it's a vein. It can collapse very nicely. Now we can see vein very nicely in the center. Okay, so and you can see also radial artery, superficial radial nerve. So can you see nerve is coming below it? Can you see in the center 2 black spots? Yes. In the center of my screen where there is yellow line. Okay, the smaller one is superficial radial nerve and the bigger one is the cephalic vein. If I glide my probe down, can you see the radial nerve is going below the vein? Can you see the radial nerve is going below the vein and coming on the other side? So if I glide it like this in the center, look, okay? Here, lots of jelly is required. Look, okay, now if I move my probe down, you can see superficial radial nerve going below the vein and coming that side, other side. Can you appreciate now?
Yes, sir.
Small,
Yes, sir.
yes, that's one small structure is. So if you focus around here, okay, just focus around here. I'll try to show you. Now you can see two spots within the structure. The smaller one is the superficial radial nerve, and the big one is the vein. Okay. In the center. Can you appreciate two black spots? See how one black spot, smaller one, will go below this vein and come to the other side. So this is basically a superficial radial nerve. This can get damaged when we are opening a IV cannula. So this is the superficial radial nerve. Okay. Now the last part is the pulley system. The pulley system basically I couldn't show you in the 3D anatomy because it was not there. But if you see how I'm putting my probe. I'm putting my probe. So linear probe. I'm putting my probe just along the long axis of the finger, okay, and over the metacarpophalangeal joint. The joint you are seeing is the metacarpophalangeal joint. Okay. Yes, sir. Okay. I'm putting my probe, linear probe, just over the metacarpophalangeal joint. Okay, and you'll be seeing the head of the metacarpal and the base of the proximal phalanx like this. Can you appreciate metacarpophalangeal joint at the center of my screen?
Yes, yes, sir.
The A1 pulley is basically located just over here, okay? Just over there. So what you do is you first palpate the head of the metacarpal and put your probe just over the metacarpal head. And you can see this is the metacarpophalangeal joint. Left side is the phalanx and the right side of the screen is the head of the metacarpal. So if I move my probe, can you see now I'm gliding towards the phalanx. So this is the long axis view of the proximal phalanx, and above the proximal phalanx you can see two tendons. The more superficial tendon is flexor digitorum superficialis. The lower tendon is basically the flexor digitorum profundus. If I tell my patient to move the finger, can you see this is gliding flexor tendon?
Mhm.
Can you
Yes, sir.
okay, that is the tendon. Superficially is the flexor digitorum superficialis,
Superficialis and
and deeper one is the flexor digitorum profundus.
profundus.
Okay, okay. So this is the metacarpophalangeal joint. This is the proximal phalanx, and this is the tendon. And so there are two tendons. Superficial is the flexor digitorum superficialis, and deeper one is flexor digitorum profundus. Okay, here this tendon, if you notice this, the tendon is like the bone. The curvature of tendon is closely associated with bone because of the pulley. Because this tendon is reinforced to the bone with 5 different pulley. So this is A1 pulley. This is A2 pulley. It is like a belt. Suppose this is the tendon and this is the bone. So pulley basically wraps around the tendon and stabilize the tendon near to the bone. So that is the main function of the pulley. So that there is no bowing of the tendon. If there was no pulley, tendon will be like this. It will not be closely associated with the bone. And because of the pulley, it is wrapping this tendon along with the it is wrapping this tendon along with the bone because of these pulleys. Okay, so this is the long axis view, and okay, so this is the long axis view. And this is the short axis view of the pulley. Okay, I'm putting my probe. Look, this is the, you can see, this is the hyperechoic structure is basically okay. So I'm freezing it here. Okay, so I'm showing you this in two plane. This one is long axis. Sorry. So this one is long axis. This one is short axis. So you can see metacarpal head of the metacarpal head. Okay, and this is the flexor digitorum superficialis and flexor digitorum profundus. But if you see it nicely, you can see a black ribbon-like structure. Okay, you can see black ribbon-like structure. It is arising from the palmar plate and it is going over the tendon, and it is basically stabilizing this tendon near to the bone. So here also, if you see very nicely here, you can see a black line here. So this one is A1 pulley. So if you see it in very nicely here, concentrate just over the tendon, you can see where I have marked red, you can see a black line. So this is the A1 pulley in a long axis. But if you want to see the pulley in short axis, this ribbon-like structure is the pulley, which basically goes over the tendon and wraps it so that there is no like subluxation or dislocation of these flexor tendon. Okay, so here you can very nicely see. So here once again pulley. So this is the head of the metacarpal, and this is the first metacarpophalangeal joint. And in this area you can see a A1 pulley. So this is the area where you can see a faint black line, ribbon-like structure over this. So this one is A1 pulley. Okay. So if we come more distally, so this is the location of A2 pulley over the shaft of the bone. So if you come more distally over the joint, this one is the interphalangeal joint. So over the interphalangeal joint will be A3 pulley. Here will be the A3 pulley. So if I come more distally, over the shaft will be the A4 pulley. And okay, so I'll explain. One more minute. Okay, I will be demonstrating this in panoramic view. Okay. So this is the panoramic view, okay? So you can very nicely see, here you can very nicely see, what you can see is, this is metacarpal, okay? This is a proximal phalanx. This is middle phalanx and this is the distal phalanx. So it is like this. Our fingers are like this, no? Okay? And you can very nicely see tendon, like a wavy tendon going there. So if you want to appreciate A1 pulley, it is metacarpophalangeal joint. So A1 pulley will be around here. A2 pulley will be around the shaft over here. A1 pulley, this is A2 pulley will be over here. A3 pulley will be over the joint. So odd over the joint. So if you see here, The odd number pulley are over the joint. Over the joint. This is the distal interphalangeal joint, and this is proximal interphalangeal joint. So if you see, odd number pulleys are just over the joint. Okay? And even number pulleys are over the shaft. So this is A2 pulley is over the shaft of proximal phalanx. A3 pulley is over the, A4 pulley is over the shaft of the middle phalanx. Okay? And cruciform pulleys are like this, crisscross pulleys from one pulley to another pulley. So this is the cruciform pulley. So as I've told you, there are two types of pulley. One is annular pulleys are like this. Okay, so A1, A2, A3 pulleys, A4 and A5 pulley. So between this annular pulley will be the crisscross shaped cruciform pulley. So between this, there will be a crisscross shaped. So these are the cruciform pulleys. Okay, so can you appreciate in this panoramic view very nicely? Yes?
Yes, sir.
So this is A1 pulley. So this is the clinical significance. Sometimes here trigger finger can happen where there will be locking of fingers like this, and where we have to voluntarily push the finger upwards like a trigger of a gun. The finger can get stuck. Once the patient flex the hand, it can get stuck, and once they open, it can be like this. It is trigger finger, and it is basically because of thickening of this A1 pulley. Where the A1 pulley is thickened, the smooth gliding of the, if the pulley is thickened, or if the tendon is thickened, the smooth gliding of the tendon below the pulley will not be there, and there will be like the finger will be stuck like this, like a trigger. Okay, so it is called trigger finger. I'm sure everybody has seen the trigger finger patient like this, and patient has to basically pull the finger upwards to relieve the trigger. So it basically happens when there is a trigger finger. Okay, so this is one view. Another view, finally I'm showing you to the short axis view. So this is the short axis view of the pulley. Where you can see a faint ribbon like freeze guard. 1 minute, right? So here you can see, this is the short axis view of the pulley. Here, if you appreciate, here black ribbon-like structure is basically around the tendon. Can you appreciate this black ribbon-like structure, thin ribbon-like structure?
Yes, sir.
So that is the pulley in a short axis. So it is easier to see pulley in short axis. And you can inject, if in the trigger finger, you can inject into the pulley about 0.2 to 0.3 ml of like steroid into the pulley and over and below the pulley. So if you want to inject in the trigger finger, your needle will come like this, above the pulley, into the pulley, and just below the pulley, you can inject about 0.2 to 0.3 ml of lignocaine and steroid. That will take care of the trigger finger. So this is it. So if you want to repeat any structure of the wrist, I can do that before Smurti goes for the pathology.
Sir, these pulleys are present in all the 5 digits.
Yes, in thumb, there is only 3 pulleys because middle phalanx is missing. But from 2nd digit to 5th digit, there are 5 pulleys are there, A1 pulley. And 3 to 4 cruciform pulleys are there between the A1 pulleys. And it is present in all the fingers. And only in thumb, there is 3 pulleys. Because in thumb, 1 phalanx is missing, no? Middle phalanx. So there is A1 pulley, A2 pulley, and A3 pulley. In thumb, there are 3 pulleys, but in others, from 2nd to 5th digit, there are 5 pulleys. 5
Okay.
A1 pulleys. Any structure you want me to show?
What about the proximal and distal intersection?
So I'm sorry, I think this is in the advanced class.
Oh, okay.
Okay, so it is in advanced class.
Thank you, sir.
Okay. Any other thing you want to see regarding this? Whatever I have demonstrated? So one last time I'm showing, though you guys haven't asked, the median nerve. Okay, final 2-3 minutes, because it is most important. And I'm showing you in mine because I've got a very good median nerve. As soon as I put my nerve, okay, first get this. First get the distal end of the radius. Okay, here you can
We
see.
said
Uh,
we can show it at the end because it's already late.
just one. Okay, final. And I'm giving it to you. Just I want to show the median nerve. Just this one. This one is the carpal tunnel median nerve in proximal carpal with the pisiform and scaphoid. So the left side of the screen is the pisiform scaphoid, and the right side of the hypoechoic structure is the pisiform. So the black structure that you can see in the center is the median nerve. So you can see the difference. How you to differentiate? Just move your toggle your probe cranially and caudally. You can see the tendon, ecotexture of the tendon will change, but the nerve will remain the same. Okay, this is the median nerve, and you always measure the cross section of the median nerve at this area, proximal carpal tunnel. And another way is to tell the patient to move the finger or glide the probe more proximally, where you can see the median nerve at the center of my screen between the flexor digitorum superficialis and profundus. So these are the three methods. Now I'm giving my this to Smruti. Okay, so Smruti will be coming with the pathology and intervention of the elbow and the wrist. Smruti, can you hear me?
Yes, yes, sir. I
Okay, you
can
can
hear you.
continue. I've already stopped the sharing. Smruti, are you there? Smruti, are you there? Hello? Hello?
Yes, am I audible, sir?
Yes, you are audible, but I cannot see your screen.
Yes, yes, there is some problem because my
You're audible.
video is my video is not starting actually, but I'm trying. Sometime this happens. Hanging the whole.
So in meantime, if there is any question, you can ask me.
So what is the concentration and volume of drug to be given in carpal tunnel syndrome?
So normally nowadays we are giving 5% dextrose. Previously we used to give lignocaine and about 20 milligram of methylprednisolone around the median nerve, which has been entrapped. But nowadays the result shows more to with the 5% dextrose. So I'm injecting about 4 to 5 ml of this 5% dextrose around the median nerve. And we also go with the long axis of the median nerve and go for tenotomy of the extensor of the flexor retinaculum. Like surgical dissection, surgeons are basically dissecting the flexor retinaculum. What we are doing is we are putting the needle either from radial or ulnar side and basically hydrodissecting the median nerve above and below in a short axis view of the median nerve. And again, we are going for the long axis view of median nerve, like I've shown you. And we are basically giving multiple puncture to the flexor retinaculum, which is just above the median nerve. And the normal drug, if you are using 5% dextrose, almost usually the volume will be 5 ml, but we can use dextrose is normal. It is compatible to the body solution, but you can give as much as you want. But normally is 4 to 5 ml. 2 to 2.5 ml the ml above the median nerve and 2 to 2.5 ml below the median nerve.
Okay.
So I'm using 5% dextrose nowadays, Tripti, because the evidence was more in favor of 5% dextrose. But sometimes you can go with 2% lignocaine and 20 milligram of methylprednisolone, 20 or 40 milligram of methylprednisolone. Here the volume of drug is same, about 4 to 5 ml.
Okay, sir. Thank you, sir.
If you want to see one video of that, I can show you. When Smriti is preparing, okay, let's see, I have video of carpal tunnel.
Yes, sir. Meanwhile, she's preparing.
I'm finding that, okay. Daradia. So meanwhile, I'll show you, okay, one video of carpal tunnels in hydrodissection. Can you see now? Can everybody see the video?
No, sir.
Hello?
Video is not seen.
Not see. Oh, wait a minute, okay. Where is the I have to open that. Can you see now video? Can you see a video?
Yes, sir.
Yes, this
Yes,
is
sir.
look how I'm dissecting. Look, so I'm basically putting my needle above the median nerve and slowly injecting 5% dextrose from above. Now I'm going below the median nerve. Look, can you see? I'm going below the median nerve now. Yes,
Yes, sir.
this
Yes,
is
sir.
how this is how we do hydrodissection of the median nerve. So I'm using 5% dextrose here. You can either use this or you can go with lignocaine and steroid. But nowadays, more evidence goes in favor in 5% dextrose hydrodissection. So this is how we do hydrodissection, okay?
Yes, sir.
Okay, very easily it can be done with ultrasound. Do you want to see pictures of pulley? Smriti, are you ready? Smriti? So I'll be showing you the pictures of the other.
Sir,
Do you want-
excuse me, sir.
Please tell me, Geetika.
Sir, while injecting the median nerve, by
Mhm.
chance, if we inject inside the nerve, if it goes by chance, will it
Yes.
affect in any way?
Yes, patient can have a few days of neuropathic pain. It can increase. The tingling and numbness can increase for a few days, 2-3 days, and it gradually will subside.
Okay, sir. Okay. Sir.
Patient will have pain. You will not be able to
Okay.
inject directly inside the nerve. It's very painful. But if
Okay.
accidentally it is injected, you will have neuritis 2-3 days, and then it will be wrong. Because if you are injecting steroid also, anti-inflammatory also, so 2-3 days pain will be exacerbated, but they will be all right.
No,
But
sir. 5% dextrose.
it will not be anything. It is a normal constituent of the body, so there will be nothing. If we are going
Okay.
to 5% dextrose, there is very very little chance of nerve damage, because it is a constituent of the body. 5%
Okay.
dextrose.
Okay, sir. Okay. Thank you, sir. Thank you.
So I'm trying to see other videos, okay, so that I can keep you guys busy.
Sir, I think Dr. Smriti is not a part of meeting.
No, I think she will join. I think she logged off, most probably. Trigger, okay, I have one trigger. So here I'll be showing one trigger finger picture, okay? I'm just keeping you guys busy. So I'm showing you one of the picture that I've taken of trigger finger, okay? This is a very nice picture. Can you see? Is it visible?
Yes, sir.
Yes, very nicely. This is a pathological slide you can see. Look, in the left side, you can see normal pulley. But in the right
Serious,
side,
sir?
aha.
Hope this
Okay.
time it's sorted out.
Okay. I'll stop sharing, okay?
I am so sorry because it's a technical problem in my laptop.
No problem.
Sir, can you please make me co-host?
Yes. Okay, 1 minute. How can we go? This option is not here with me, host.
Sir, I think sir can make me co-host.
You can just call him. Can you call? Just call him. WhatsApp.
Okay.
Will I call?
Yes, we need to call sir.
I'll call him. Okay.
Mhm.
Is visible.
Yes.
Okay.
Okay. So, good evening, everyone. Here today, our topic of discussion will be some of the elbow and wrist pathologies that are more important and for basic for the basic classes, and few basic examinations that are needed. And here we will start with the first. There are few basic steps before knowing the elbow and wrist examinations. Those are, first, in the OPD, you should know how to rule out the red flag and what can be the red flags for your wrist and elbow pathologies. Like mostly wrist and elbow pathologies, any nerve injury, any compartment syndrome, any fracture, any infection. These are very common red flags here. Then after ruling out the red flags as a common pain in a pain clinic, then we have to take the history, few examination, and this is the standard protocols in a pain clinic to start the examination. These are the few things that you should remember, like inspection, palpation, range of motion, neurological examination, and few special tests. These are the sequence of examinations that we follow for wrist and elbow examination. Then coming to the presenting illness, how especially what usually patient complain in the wrist and elbow, main complaint is your pain. So pain, what are the, where exactly pain is localized, how is the intensity, mild, moderate, severe, quality of the pain, then whether it is radiating or non-radiating, what aggravates the pain, or what are the factors that relieve the pain, or whether pain is, see, pain is radiation of the pain or pain localized at any other side. There are two different things. Some patient will complain that pain is radiating from the elbow to the wrist, and few patient complain pain is present in the elbow and pain is present also in the wrist. So these are two different things that we should differentiate. Then, and these are the things that we need to ask the complaint of the pain. Then what are the associated symptoms? Associated symptoms like whether it is associated with tingling, numbness, whether pain is associated with morning stiffness or night pain. What does it mean by morning stiffness or night stiffness? Whether is there any inflammatory pathology that is associated with the pain, or any muscle weakness or grip strength that we need to rule out, any neuropathic pain or any nerve weakness, or any radicular pain or any nerve root compression, or any there is any compressed entrapment neuropathy. These we should rule out by asking this question. So any associated systemic complaints, then systemic complaints, so or any other comorbidities like diabetes, other post-herpetic neuralgia, hypothyroidism, these are also sometimes associated with neuropathic pain. Then, so here is in the past history, we need to ask any history of trauma, any history of injury, any surgery, any CRPS history, or any history of diabetes, because prolonged diabetes history may suggest painful diabetic neuropathy that is very common in the upper arm, that is the wrist, in the gloves and stockings pattern. So history of hypothyroidism, hypothyroid patients are more prone to carpal tunnel syndrome. Fibromyalgia patients, commonly these patients usually coexist with carpal tunnel syndrome. Obesity is another risk factor for carpal tunnel syndrome. Inflammatory arthropathy, usually in inflammatory arthropathies, your elbow arthritis, in bursitis, tendinitis, or enthesitis, or any neuropathic or entrapment neuropathy are also common with inflammatory arthropathies. That's why these history are clinically relevant to your symptoms. So we should rule out by asking these questions, or any any relevance between the symptoms and the history. Then coming to personal history, history of smoking. Smoking is usually, smokers are more prone to degenerative arthropathy. Smokers are more prone to vascular disease. Similar way, alcohols and drug abuse are also, these patients are more prone to Lifestyle disease like diabetes, any vascular disease, atherosclerotic arterial disease, this history also carries equally significance. So they're coming to occupational history, like history of repetitive use or activities. This history may suggest some tendinitis like tennis elbow, golfer's elbow. This is very common in those patients who are involved in some repetitive activities. Then coming to the physical examination, suppose in the wrist examination, how will you examine? If there is any swelling, if there is any redness, any deformity, where it is seen usually in inflammatory arthropathy like rheumatoid arthritis, you can see the swelling. These are the very common findings in the rheumatoid arthritis, small joint swelling, redness, effusion. Then degenerative changes like first metacarpal joint arthritis, degenerative arthritis, you can see these changes. Or atrophy of muscles or skin changes you can see in the other autoimmune disease, or atrophy of muscles you can see in some nerve paralysis like ulnar nerve palsy, or any entrapment neuropathy also you can see. Then what physical examination of the elbow, what things you can see in the inspection of the elbow you can see the deformity, angle, whether there is an increased angle, you can see there is medial collateral ligament or lateral collateral ligament injury in the elbow may lead to increased angle. Or if there is any fracture, you can see deformity or increased angulation. Then you can see the degenerative changes, atrophy of muscles or skin changes. You can, and also swelling, redness, olecranon bursitis, you can see swelling, redness, and also nodules you can see sometimes in some inflammatory arthropathies. Then on examination, palpation of the wrist, you can see crepitus, swelling, if there is any joint effusion. Then tenderness, effusion, you can see in any inflammatory arthropathies, or sometimes in degenerative arthropathies also. Same in the elbow examination also, we can see crepitus, swelling, and once you palpate in elbow arthritis, inflammatory arthropathy, or rheumatoid arthritis, we can palpate the antecubital fossa, we can see the palpate the crepitus also on movement. Then tenderness in the lateral epicondyle, medial epicondyle, in tennis elbow, golfer's elbow, effusion, posterior elbow, usually commonly we can palpate, and distal end of radius and ulna, there will be tenderness if there is an arthritis. Similar way, range of motion, then after inspection and palpation, there comes range of motion. Range of motion, there is a elbow is range of motion is somehow restricted, and mostly elbow is flexion and extension is common. And elbow is there is most commonly you can see the movement is flexion, and you can see how flexion can be done by bending the elbow towards the shoulder, and this movement is now 0 to maximum 150 degree. Extension, similarly, once you can straighten the elbow, moving away from the shoulder. And normally what happened, normally it's 0 degree means from you can extend only mild, up to 10 degree is common. But sometimes few hyperextension is also common in few patients, few people. And pronation, here rotation of forearm so that palm should face downward. This is the pronation, and this range is normally 0 to 80 to 90 degree. And supination is rotating the forearm so that palm face upward. And here same, pronation and supination is equal 80 to 90 degree. Then coming to wrist range of motion, say wrist also, there is flexion of the wrist by bending the wrist so that palm moves closer to the hand. And here your range is 0 to 80 degree, and extension, you can maximally straighten the wrist so that back of the hand moves closer to the forearm. And this range is 0 to 70 degree. And another movement are abduction and adduction. Maximum abduction is called radial deviation, and it is maximum 0 to 20 degree. And adduction is ulnar deviation, maximum 0 to 30 to 40 degree. Then there are few special tests that we need to perform in different conditions. And these are few special tests I have written, and during a pathology condition, I have I will mention few other special tests here. Finkelstein test. Finkelstein test. What is Finkelstein test? Usually it is done for de Quervain's Tenosynovitis, where you will make a fist by thumb inside the finger, and then you will do the ulnar deviation of the wrist. And you can feel the pain along the thumb side. That means positive of the de Quervain's Tenosynovitis. Another special test commonly performed for the entrapment neuropathy is renal sign. Here, the patient is asked to place the palm upward and examiner bring the affected hand into full dorsiflexion to compress the, here you can see, compress the carpal tunnel with flexure retinaculum. And here the examiner percusses the median nerve using a broad-based knee hammer. And here, if patient will feel paresthesia in the thumb, index, and middle finger, then that means there is a positive Tinel sign. Then Fannel's test is phalanx test. What happens here? In the patient is asked to allow the wrist to hang downward in a fully but not forced palmar flexed position for a minimum of 30 seconds. And it is positive if symptoms are produced. Spread sign, patient is asked to spread the fingers apart as far as possible in comfortable relaxed position on the examination table. If patient is unable to spread 2 or more finger apart, then it is positive. Then coming to, these are few special tests for the wrist, and these are few special tests for elbow. One is varus and valgus test. This is for ligament, medial and lateral ligament. Here in standing position, abduct the shoulder and patient is asked to flex the elbow 30 degree and exert varus stress test for medial ligament, and valgus test is done for lateral ligaments. Another is tennis elbow test. Here, what is done? The patient test is performed. How? By stabilizing the patient's forearm and having the patient clench the fist and actively extend the wrist. Now, examiner attempt to force the wrist into flexion. If there is sudden severe pain, then this test is positive. Similar, the opposite of this test is golfer's elbow test. What is this done? The patient's forearm is stabilized, and then patient is asked to actively flex the wrist, and the patient will try to extend the wrist. If there is sudden severe pain, then it is golfer's elbow test positive. Then we will discuss few common wrist pathologies. Here I am not going details into the examination part. All these tests and examination are written in the clinical methods book. Please go through once. All the tests has been written there with good pictures. There you can see, and please revise it few times so that you can be performing nicely. And these are few common wrist pathologies like carpal tunnel syndrome, and Siri sir has explained very nicely. Then second is de Quervain's Tenosynovitis, ganglion cyst, TFCC, that is the triangular fibrocartilage complex tear, wrist osteoarthritis, trigger finger, and Guyon's canal system syndrome. These are few common wrist pathologies that we will go one by one. The first of all, I will discuss this as a case history because everything I have included, including risk factors, signs, and symptoms. You can see this is a 45-year-old female. Carpal tunnel syndrome are very common in females than males of 90 kg. The carpal tunnel syndrome is common in obese females. And non-diabetic, diabetes is another risk factor. Hypothyroidism is another risk factor. Rheumatoid arthritis also a risk factor for carpal tunnel syndrome. And since 5 years, and now she is presenting with tingling, burning pain in the thumb, index, and middle finger. Carpal tunnel syndrome, it is commonly patient complaints of pain, tingling, and numbness mainly in the thumb, then index and middle finger. Sometimes the medial half of the ring finger, but rarely, but mostly these 3 fingers usually they complain. And sometimes they will feel numbness, like they will feel something is swollen, my fingers are swollen, and pin prick sensation. Since 6 months, initially they usually complain that pain is more at night, and after shaking the hand or after moving the hand, the pain goes away. But gradually, what happens? The pain becomes continuous and become more severe gradually. And as she has given a history of long duration pain, you see, initially it was at night, but since 15 days, it is moderate to severe and continuous. And earlier, she was on pregabalin 75 milligrams since 3 months, but it is not working now. And SIDS was also of no use. She had tried steroid injection once with a short-term relief, but again, same pain reappeared. On examination, there was a slight reduced sensation in thinner area, because all of you know that anatomy, median nerve supply the thinner muscles, but thinner muscle strength is intact. That means it is compression is not that severe. Tinel sign and Fallon's sign is positive. As we have discussed the special test, Tinel's and Fallon's sign, these are positive, and abduction of thumb is normal. The function of median nerve supply, the abductor of the thumb is supplied by median nerve. So here still the nerve is intact, and here you can see the ultrasound of the median nerve. It is uniformly hypoechoic. And here I have shown the ultrasound picture. You can see the nerve, usually normally nerve is hypoechoic with hyperechoic dots, but here you can see in this picture the hyperechoic dots are also not clearly visible. So this is not looking like a typical of nerve. There is somehow it is swollen. And in the ultrasound examination also, there is an edema, increased cross-sectional area of 13 millimeter. So normal thickness of median nerve is less than 10 millimeter. When you will say it's a carpal tunnel syndrome, moderate, it is if it is more than 10 millimeter. And if it is more than 15 millimeter, then it is a severe carpal tunnel syndrome. And if more diameter, then symptoms are also accordingly. And if maximum cross-sectional area of the nerve is near the proximal end of the carpal tunnel, that is also known as notch sign. You can see the notch sign in this picture. You see how it is thickened. Okay, this is the proximal end. And this is how the nerve looks in the short axis, and this is how it looks in the long axis. Median nerve maximum at the proximal end of the carpal tunnel. So that's why hydrodissection is also done at the proximal end. So we have planned for hydrodissection of median nerve with 5% dextrose. Earlier, we used to, as steroid has already given and it was not that effective. So 5% dextrose and fenestration of the flexure tendon sheath also, fenestration of flexor retinaculum has been planned. Why flexure retinaculum has been planned? Because it is less chance of recurrence when there is a fenestration of flexor retinaculum done. But why we are not giving steroid again? Can anybody answer? Should we go for steroid along with dextrose hydrodissection?
Patient has already received a dose of steroid, I think.
Okay.
Repeatedly, we can't give the steroid, madam. But 5% dextrose, we can repeat.
Okay. But steroid, if we inject steroid, there is a chance of recurrence. Okay. Dextrose has least chance of recurrence. And this fenestration of the flexor retinaculum has a better efficacy, even more better efficacy than surgery. Then next is dequervance tenosynovitis. Dequervance tenosynovitis, this is another case. Here is a 34-year-old female who presented with a pain and swelling at the base of the thumb and wrist, particularly on the radial side. The pain started gradually over the past 3 months and has worsened with gripping object and performing the repetitive hand movement at work. And on examination, there is swelling and tenderness over the radial aspect of the wrist, specifically near the first dorsal compartment, where abductor pollicis longus tendon and extensor pollicis brevis tendon pass. Tenderness along the radial styloid process and first dorsal compartment. Why this dequervance tenosynovitis is common at this site over the radial styloid process? Because here there is friction of these two tendons over the radial styloid process that causes the inflammation. And here the Finkelstein test is already I have discussed, it is positive, and range of motion is limited, wrist and thumb movement due to pain. And she has already given NSAIDs on and off for 3 months without any adequate relief. And here you see there is a pain and swelling also where it is at the base of thumb. Here there is swelling and pain. In the diagram you can see, and particularly on the radial side, and I think most of this is a very common condition, and all of you must have seen a case in your practice. And most of you have also done ultrasound examination, and under ultrasound examination you must have seen this kind of picture also, where there is a thickening of the tendon sheath. You can see tendon sheath, that is the white area surrounding the tendon, and inside there will be accumulation of the fluid, and there is edema. Tendon, usually this much thickness is not present, and you see this blackish area is not normally seen. And when there is edema and fluid accumulation, this tendon swollen and looks like this. And in the long axis also, this thickness is not normal. And if when it is acute, you can see increased thickness in the ultrasound on the long axis also, and you see there is some hypoechogenicity over the tendon sheath also. So here we plan peritendinous steroid injection with, again here, fenestration of tendon sheath. In my practice, I have seen that penetration of the tendon sheath is more effective than only giving steroid injection, because sometimes dequervance tenosynovitis also recurs even after giving steroid injections. So penetration of the sheath is a good practice. And what else can be done in this case? Can we give PRP?
Role therapy, PRP,
Yes, PRP can be done. But when you see hypervascularity or something, then steroid is a better choice in this case. But if it is longer duration and no more inflammatory changes, only degenerative changes, you can try PRP also. PRP or dextrose prolotherapy. Then coming to the third case, ganglion cyst. Ganglion cysts are also common. These are also cases you must be seeing in your daily OPD, but patient usually do not come because these are painless lump. These patients, they do not visit OPD because they unless and until there is symptom, they won't come to you. And if somebody is concerned about their or there is some cosmetic region, there's some about the looks of their hand, they won't come. If there is an increase in the, or they will notice increase in the size or something, like this patient, he is a software developer. When he noticed a painless lump over the dorsal aspect of the wrist that gradually increased size over past 6 months without any significant pain or functional impairment, but has been concerning for the patient due to its appearance. On inspection, a well-defined soft and fluctuant mass that is observed on the dorsal side of the wrist near the, and usually it is very common at the joint or at the tendon. Okay, here you see it is very common near the scapholunate joint, and the mass is translucent and it moves with the wrist flexion. Commonly, it originates from the tendon sheath, and that's why it moves with flexion extension along with the movement of the tendon. And sometimes it is tender and palpation and usually compressible, and there is no redness or warmth unless and until it is inflamed or infected, and it doesn't hamper the movement of the joint. And here you can see usually what happens, sometimes this cyst resolves spontaneously. They do not need intervention by some activity modification or some over the counter medications. Also pain goes up. But if there is any inflammation or there is increase in size, you can try aspiration of the cyst. On aspiration you will find some gelatinous fluid, and you can give some steroids so that cyst will automatically, that will not recur. Usually methylprednisolone or deposteroid, they prevent recurrence. Next is your TFCC, triangular fibrocartilage complex. This is an important uh, pathology, triangular fibrocartilage complex. I think this is a, you can see this is the ulna, and this is the triangular fibrocartilage complex in the ulnar side, lateral ulnar triquetral area. Here, this is a case of 34-year-old graphic designer who complained occasional wrist discomfort and due to repetitive strain from work, and she presented with persistent pain and weakness on the ulnar side of wrist. There is usually they used to complain pain at this area, ulnar side of the wrist joint, and the pain starts about 6 weeks ago with a minor fall where she landed in her extended wrist. She reports increased pain with the wrist rotation, especially when lifting objects or during activities that involve gripping. Holding something is painful for her, or when she lifts something that aggravates her pain. And while examining, there was mild swelling on the ulnar side of the wrist joint. Usually, some patient complain this side is painful, ulnar side of the wrist is painful. And this triangular fibrocartilage TFCC injury is most of the time is undiagnosed. And most of the time, this mimics wrist arthritis. And most of the time, people misdiagnose it as a wrist arthritis, but actually the scene is something different. Here you see, because most of, even they on rotation of the wrist, you find crepitus also, and there is a reduced range of motion in the wrist extension and ulnar deviation. But how will you diagnose whether it is a TFCC injury? By some tests, like you see, these are common. This tenderness, crepitus. These are also found in the wrist. Wrist arthritis. But the few special tests are there. TFCC compression test, it comes positive. How will you do this special test? When pain is reproduced, when you compress the wrist joint, while the patient performs the ulnar deviation. Okay. And another test is ulnar grind test. When pain and clicking are elicited when the examiner rotates the wrist while applying the axial compression. And X-ray doesn't show any abnormality, but here in the TFCC injury, you can diagnose with ultrasound by, you can see there is increased vascularity, there is hypoechogenicity in this area, triangular fibrocartilage complex in this area. But MRI is the gold standard for diagnosing TFCC injury. There you can see tear or degeneration. And there are some signal changes in the fibrocartilage complex with increased fluid in the wrist joint. And here its management, usually TFCC injury management is usually initially we follow the RICE protocol, like wrist splint usually asked to wear for 4 to 6 weeks. and then rest, that means rest, then ice compression, then some non-steroid NSAIDs, then physiotherapy, then interventional treatment. Here also, this patient also has taken PRP of TFCC. Usually 3 sessions of PRP tried for optimal relief, and some other modalities also has been tried, like corticosteroid injections. Then here arthroscopy evaluation also, if there is symptoms severe, persistent, and there is significant functional impairment, then you can go for an arthroscopic evaluation and surgical treatment. If all the measures intervention fails, then go for a surgical treatment. But patient education is the most important thing here. Then coming to wrist osteoarthritis, first carpometacarpal joint arthritis is the second most degenerative arthritis after osteoarthritis knee. And here you will find pain and stiffness at the base of the thumb, especially when gripping or pinching. The pain is described as aching or throbbing pain, and it is aggravated by a patient will something writing or opening jar or using tool. Even sometimes few female patients, they will complain when they will pinning something or using safety pin, opening or closing the safety pin, they will feel pain. And I've seen many patients like that, and mild swelling and tenderness in the base of the thumb. And there is limited range of motion of the thumb, particularly abduction and opposition. And here also positive grind test, that is the compression test. And you can see when rotation of the thumb, any movement, you can rotate or abduction. Rotation and abduction usually painful. These are the 2 tests you can go for wrist osteoarthritis. And X-ray shows joint space narrowing, osteophyte formation, and subchondral cyst at the first CMC joint. And same for the wrist joint also. And here you can try corticosteroid injection to reduce the inflammation and temporary. You can see the picture how the ultrasound-guided injection usually tried. For the here is the trapezium. Here is the first metacarpal, and this is the first CMC joint. And you can go in plane technique under USG guidance by using a linear probe. Then coming to the Guyon's canal syndrome, and sir has shown very nicely the Guyon's canal. I'm not going into the anatomy because all of you are clear about the boundaries of Guyon's canal, roof, floor, because this anatomy is very important for your all the competitive exam, and you need to remember this. Guyon's canal. So I'm directly coming to the signs and symptoms. Here, pain and paresthesia in the ulnar 1.5 digit, the little finger and ring finger. Okay, these 2 fingers will be affected. Here, there is a clawing of the ring and little, that is called the ulnar claw hand, is common in Guyon's canal syndrome. And here there is, due to loss of intrinsic flexing the metacarpophalangeal and extending the interphalangeal joint. So there is paralysis of the intrinsic muscles of the wrist, that is the abductor pollicis, and deep head of the flexor pollicis brevis, interosseous, and lumbricals 3 and 4, which are supplied by the ulnar nerve. And there is a weakened grasp from the loss of metaphalangeal joint and flexion power. And there is a wing pinch from loss of thumb abduction. And Froment sign is positive, and Wartenberg sign is positive. Wartenberg sign is abduction posturing of the little finger. And you can go for hydrodissection of the nerve at the Guyon's canal. You can see from the lateral, from the ulnar side, put a linear probe, and you can come from lateral to medial with a linear probe, as it is very superficial. With a small 1 inch needle, you can 1 or 1.5 inch needle, you can come, and with 5% dextrose, you can give 5 ml surrounding the nerve, and you can see a clear halo sign here surrounding the nerve, and it will take 5 to 7 days, but it can take longer because this entrapment neuropathy effect comes after a long time. So these are the pictures of the Gans canal syndrome. Then coming to trigger finger. This is a pathology of A1 pulley. A1 pulley, you can see this is a schematic diagram how A1 pulley is located over the head of the metacarpal, first metacarpal head. You see this green line is your A1 pulley, and this is the orange one is your volar plate, and the light blue shade is your flexor tendon. Okay. So here, what are the symptoms of the trigger finger? Pain and locking of the finger, especially when you try to straighten it, it will not straighten directly. Here, what happened? Patient will describe a catching or snapping sensation. And you can see the tenderness over the A1 pulley, where it is located at the base of the finger, where the tendon passed through. And ultrasound, you will you can see the ultrasound picture. There is a thickening of the A1 pulley or tendon sheath. And you can see sometimes there are some nodules present over the tendon that will cause the trigger finger. And ultrasound, and what are the treatment? USG guided corticosteroid injection into the affected area to reduce the inflammation and the swelling. So you can come directly in the implant technique and inject just below the A1 pulley and over the flexor tendon sheath. Okay, below this will look white hyperechoic, and this tendon will look like a hyperechoic with hypoechoic lines, and in between this some black area will look, and our target is that black area. And these are few common elbow pathologies. And as this is a basic class, I'm focusing on the main common elbow pathologies. So here, lateral epicondylitis or medial epicondylitis, I am discussing both together because both are very similar to each other. Here, it's a common case history with I'm combining these two together. So here, it's a 32-year-old. This is for your common understanding. 32-year-old female patient, pain and discomfort on the outer aspect of the right elbow, or you can say the medial aspect of the right elbow, and present about 8 months. Okay, and have been progressively worsening with dull ache and aggravated with gripping or lifting object. On examination, you can find tenderness localized to the lateral or medial epicondyle, which is the bony prominence on the outer side or inner side of the elbow, or you can say the medial side or lateral side of the elbow. Here, for the lateral epicondylitis, there are two special tests. One is Cousins test and one is Mills test. What is Cousins test? That is pain with registered wrist extension. And what is Mills test? Pain with passive wrist flexion and elbow extension. These two tests are positive for lateral epicondylitis. And for medial epicondylitis tests, this test is positive when pain with registered opposite, that is the registered wrist flexion and pronation. And patient may also report pain with palpation directly over the medial epicondyle. And ultrasound shows degeneration or thickening of the flexor or extensor tendon. And here also, this is this lateral or medial epicondylitis, initial acute lateral or medial epicondylitis should be initially treated with RICE protocol, rest, ice, and some analgesics like NSAIDs, physical therapy, brace or splint. It comes as a tennis elbow or golfer's elbow brace. Then if that is not treated with conservative management, you can try corticosteroid injection. But usually, most of the patient, they get corrected with the peritendinous corticosteroid injection. And also another treatment, extracorporeal shock wave therapy. that also gives good result in these cases. Usually that also gives 50% results and also better also. In this case, it lasted for 50% pain relief. So still pain was there, mild, moderate pain lasted for 1 year, 1.5 years. So PRP can be planned in this case. And here, this is the aim of PRP here was to promote healing and prevent the recurrence. And here, PRP, one session has been given, and with one session of PRP, patient pain was relieved, and it did not come back. With a patient was followed up regularly. You can see how you will inject. Here, this is a common extensor tendinitis. This is the common extensor tendon. And here, once you give injection, this is the peritendinous injection. But if you want to give PRP, then you can do tenotomy and intratendinous injection you can give. And this is a common flexor tendon intervention. Here you see the needle came to the common flexor tendon directly. And this is the common flexor tendon. You can inject inside the tendinous mass. And this area below the CFT, this is your medial collateral ligament area. Sometimes you can see the medial collateral ligament, that is also called ulnar collateral ligament injury. Sometimes if there is some injury or tear, ulnar collateral ligament injury also seen in some patients. There also you can directly go there and give PRP in these cases. Then come to olecranon bursitis. Olecranon bursitis is very easy to diagnose. You can see the posterior elbow, it is very clearly seen there is swelling, redness over the posterior elbow and the olecranon area, and swelling and discomfort. There is dull aching pain, and patient will report there is increased pain when you put pressure, and over the swelling you can see the typical cystic appearance and fluctuant nature of the cyst, and you can easily under ultrasound guidance you can see the fluid filled black area over the bony prominence, and you can directly aspirate and inject, or under ultrasound guidance also you can aspirate and give corticosteroid injection. Then come to radial tunnel syndrome. Radial tunnel syndrome is a misnomer where usually what happens most of the time in many articles it is written deep branch of radial nerve entrapment, radial tunnel syndrome, PIN, posterior interosseous nerve entrapment, but most of the articles they usually suggest this is the deep branch of radial nerve entrapment, which is located between the two heads of the supinator. In the and here in the radial tunnel syndrome, here there is no sensory or motor changes. Patient will feel only discomfort and pain, dull aching pain. So most of the time people confuse this with lateral epicondylitis. And the location is also like most of the time the pain is just distal to the lateral epicondyle. That area pain will be localized. And here you can see the area where pain will be localized. Here a lateral forearm near the elbow, and sometimes it can radiate to wrist or elbow and localize to radial tunnel. And pain usually it is worsened with activity, and when you extend the wrist or forearm supination it usually relieved by rest because it lies between two heads of supinator. So with movement of the supinator the pain worsens. And sensory changes, but here unlike carpal tunnel syndrome, radial tunnel syndrome, it doesn't have any sensory or motor changes. There is no numbness, no tingling, nothing will happen. But once you see in the ultrasound, you see elbow in the semi-prone position, just distal to the elbow joint, you can see how they have put the probe. You can see the over the radius between the two head of supinator. This is the nerve, and how you can hydrodissect. You see the radial nerve. Here you will see black large hypoechoic nerve, and there is compression and impingement will increase the nerve and between an inflammation, and also you can notice the edema surrounding the nerve also. And there will be increased echogenicity around the nerve. But that's why ultrasound is the only diagnostic test for the radial tunnel syndrome, because if you will do EMG or NCB, everything will come normal. And the only treatment is hydrodissection of the nerve, hydrodissection of the nerve in this supinator group. Between two heads of supinator, you just inject 7 to 10 ml of the 5% dextrose. And you can clearly see the halo sign in the short axis, in the long axis, just hydrodissection. Then coming to the elbow arthritis, there is pain, stiffness, and decreased range of motion in the elbow. There is a deep aching pain that worsens with the movement and improves with the rest. But when it is an inflammatory arthropathy, then it will improve with movement and worsen with rest. That's how you will differentiate elbow arthritis, whether it is inflammatory or degenerative. Most commonly, elbow arthritis is inflammatory. Degenerative elbow arthritis is very rare, but inflammatory elbow arthritis is very common. And most common cause is rheumatoid arthritis. And swelling and mild deformity usually present. And elbow osteoarthritis, the skin over the elbow may be warm because due to inflammation. And you will find tenderness over the elbow joint, around the medial and lateral aspect. There is bony enlargement. Sometimes with when you will do X-ray, you can see osteophyte formation, range of motion is reduced, and both flexion and extension will be reduced. Crepitations on movement, as your knee effusion sometime present. How will you differentiate? How will you appreciate the effusion? By ultrasound examination, you can see the lifting of the fat pad in the ulnotrochlear and radiohumeral joint. You see how this is lifting of the fat pad. Similar way in the posterior joint also, same picture you can see. And X-ray also you can see the same changes, bone spur, subchondral sclerosis, and ultrasound you can see effusion, synovitis, and also cartilage damage. This is the black cartilage area will be reduced. So you can approach either through this joint, radiohumeral or ulnotrochlear or posterior. There are 3 approaches. Any of this you can approach. Then coming to the cubital tunnel syndrome. Cubital tunnel syndrome, this is also another important entrapment neuropathy. You remember this boundaries. These are very commonly asked questions in all your exams. There is also numbness and tingling in the ring and little finger. How this is different? You see from the Guyon's canal syndrome. There is a weakness in the hand. Okay, the intermittent numbness and tingling, but there is a sensory deficit in the dorsum of the hand and tenderness over the ulnar nerve when you palpate in the cubital tunnel between the medial epicondyle and the olecranon and inner side of the elbow. You will see there will be tenderness. And when you flex the elbow, that is called elbow flexion test, will come positive. When elbow is flexed, even you will flex for 1 minute, then there will be tingling and numbness in the ring and little finger will start. And then Tinel sign become positive. There will be tingling and electric shock like sensation when you will tap over the ulnar nerve between the medial epicondyle and olecranon process. Then weakness testing. There will be when you will ask the patient to grip, hand grip and finger abduction. There will be reduced strength, particularly in the ring and the little finger. And when you check in the ultrasound, you see the ultrasound picture of the ulnar nerve in that group. You see in the cubital tunnel, there is flattening of the nerve and increased thickness of the nerve. But here the EMG and NCB test will come positive. And there is a motor deficit to ulnar innervated extrinsic muscle. And same treatment is same for all the entrapment neuropathy and hydrodissection of the nerve in the cubital tunnel with 5% dextrose in the short axis and long axis. And you can inject, come like this from the medial epicondyle side. You can inject surrounding the nerve and create a halo sign, or you can say owl's eye-like sign. Another important pathology of the elbow is distal biceps tendon tear. Here in the distal biceps tendon, there is pain and weakness in the elbow. Patient will find difficulty in flexion and supination. With some difficulty in performing, patient will unable to lift some object. There will be difficulty in lifting activity, and there will be a sharp sensation in elbow with persistent aching in the upper arm. Even if there sometimes patient will say there is a swelling in my upper arm and there is weakness in the biceps. Whatever activity biceps muscle does, there is a weakness in that muscle activity. What biceps does? Flexion. Anything that involves flexion of your wrist will be weak. So mild swelling in the elbow joint also, because all of you know where biceps tendon insert into the radial tuberosity. So you can see when there is an inflammation of the biceps insertion, there will be a effusion of the elbow joint. So that's why, that is the reason swelling in the elbow joint is seen, and the biceps may appear slightly abnormal but without bulging. And tenderness in the region of the distal biceps insertion, where you can see in this area we will find tenderness, because this is the area where biceps tendon inserted. You will see biceps squeeze test. Some weakness or discomfort is noted when you squeeze the biceps tendon. Okay. And hook test. How will you do hook? Just hook around the biceps tendon distal area. Okay. The examiner may still be able to hook the tendon partially when there is partial tear, but when complete tear, he or she will not able to hook. Patient may experience discomfort or difficulty. Ultrasound, when there is partial tear, there will be thinning of the distal bicep tendon, because half of the tendon is already torn down, and the tear may be visible when disruption in the tendon fiber without complete detachment. Here, the most commonly PRP is done, steroid is not done. In corticosteroid injection is not usually given. These are few common pathology. These are the pictures you should remember. How does it look? Calcific tendinitis. You see, these are the white hyperechoic things. This is a calcific tendinitis of common extensor tendon. See how this calcification look under C-arm guidance. And X-ray also, this looks like this. And partial tear, you see, this is a big tear. This area look black. And when you put color Doppler, it will take color. Okay. Thank you for your kind listening. If you have any doubt, you can ask me. These are for basic course.
Hello.
Yes.
Yes.
Dr.
Gitartha.
Yes, Dr. Gitartha, please stay.
Yeah, for any peritendinous in steroid injection, so we are injecting outside the tendon sheet or between the tendon and the tendon sheet?
We are injecting around the tendon sheath.
Okay, so it is outside the, it should be outside the tendon sheet.
Outside, yes.
Thank you.
Is there any harm if we accidentally inject inside the tendon?
Actually, steroid injection, especially deposteroid, accidental injection also, sometimes it may cause tendon tear, rupture. rupture of the tendon. That carries the risk.
And
So
what
we
about
should be very
5%?
careful.
And what about 5% dextrose? Can it lead to any injury to the tendon if given inside accidentally given into the tendon?
Yes, a 5% dextrose, 12.5% dextrose can be injected into the tendon because these are usually given intratendinous.
Okay.
Any other doubt? Okay then. Sirish sir, are you there?